welcome on this wonderful Sunday morning to our update in diabetes from the Ruby Hall Department of Diabetes and Endocrinology. We are very happy to have you on board, and we look forward to excellent academic discussion for the next about 4 hours or so. We've got a galaxy of speakers who are all part of this department, and I'm very proud to say that we have a very highly trained, people with the Department of Diabetes and Endocrinology, which you're just going to see the kind of work all of us do to see that we can bring quality care in diabetes, in the city of Pune. We're proud to say that Ruby Hall Clinic is one of the most advanced hospitals in terms of care, diagnostics, and in many other fronts. So with this short introduction, I'm going to hand over the proceedings to Dr. Ritu, who's going to be the master of ceremonies today. And we're going to have some wonderful lectures by our faculty at the Ruby Hall Clinic. We would like you to visit our hospital and see the department for all the various activities that we are doing from this department, with meet all the consultants who are part of this endeavor. And I'm sure over a period of time, we will evolve even more and bring this department up to world standards. So look forward to have you, and I hope you have a great learning morning. With this, over to you, Ritu, for taking the proceedings further.
Thank you, sir. Good morning, everyone. Welcome to the webinar on Diabetic Update 2022. Let's welcome our first speaker, Dr. Meghna Chawla, who will be speaking on approach to diabetes in children. Dr. Meghna Chawla is working as consultant pediatric and adolescent endocrinologist in Ruby Hall Clinic. She has expertise in growth disorders, disorders of sexual differentiation, pubertal disorders, type 1 diabetes, obesity, and type 2 diabetes, disorders of bone and mineral metabolism. Ma'am, let's start. Handing over to Dr. Meghna Chawla.
Thank you very much for the kind introduction, and good morning, everyone, for joining in to today's update. And let's right away start with the first lecture. And since I'm a pediatric endocrinologist at Ruby Hall Clinic Hospitals Group, we would just have a brief overview as to how to approach diabetes in children. I can tell you one thing: diabetes, especially type 1 diabetes, is increasing by leaps and bounds today. And I'm sure all of us who are managing children with type 1 diabetes would agree with me on this particular thing. So let's first go to the types of diabetes in children. As we all know, type 1 diabetes is the most common, and it comprises more than 90% of the cases that we see in children and adolescents. And we're not far behind thanks to the parallel epidemic of obesity going on. We are seeing increasing number of children who are coming in with type 2 diabetes. So type 2 diabetes, especially post-pandemic, is another thing that is increasing exponentially. And anyone who is in a pediatric setup will fully agree with me that the BMI of children, due to the online schooling, due to the COVID pandemic, is certainly much higher than the pre-pandemic levels. And this has caused some kind of metabolic derangements, especially type 2 diabetes. To see this, a short view of the magnitude, more than 425 million people worldwide have diabetes. And this is what is that no family currently is untouched by the condition. A quick look at the symptoms of type 1 diabetes in children. As we all know, but let me reinforce it, polyuria and polydipsia are some of the early signs that they can present with. Another important clinical clue that you get in history is that they eat a lot, but despite eating a lot, they are losing weight. So loss of weight, involuntary weight loss, is because they are eating, but due to the increased osmolarity, they're losing all the calories in the urine. So if any parent comes to you with the complaints of that the child is eating well but losing weight, the first thing you need to do is check the blood sugar. The magnitude of the problem is huge. Overall, approximately 96,000 children under the age of 15 are estimated to develop type 1 diabetes annually worldwide. An increased incidence of type 1 diabetes has been observed globally in the recent years, including developing countries like India, which are in states of nutrition transition. Epidemiological studies have also shown the risk of type 2 diabetes to be 1 to 50 per 1,000 children worldwide. It is plateauing somewhere in the Western world, the incidence of type 2 diabetes and obesity. But in countries of nutritional and secular transitions like ours, it is certainly on the uprise. A quick look at some of the Indian studies. I could find this interesting study that was published by Dr. Mohan and his team regarding the clinical profile and outcome of infantile onset diabetes mellitus in southern India. And they studied 40 patients with neonatal diabetes or infant onset diabetes mellitus. And they concluded that almost 67.5% of them had actually presented initially with diabetic ketoacidosis. So it's really tough to pick up symptoms and signs in infants. And by the time they do, it's a little too late, and they usually present to us with DKA. So the risk factors that they concluded for DKA are younger children less than 2 years, a delayed diagnosis, and lower socioeconomic strata. A quick look at the types of diabetes in children. Type 1 diabetes, as already stressed before, is immune-mediated. And there is a non-immune-mediated type 1 diabetes that is coming up, which is called idiopathic. The autoantibodies that are responsible for type 1 diabetes are a few of them, which may be present. Then they are immune-mediated. If they are absent, then they are idiopathic. Type 2 diabetes is already mentioned. The other type of diabetes are maturity onset diabetes of the young and neonatal diabetes, which comprise of, under the broad classification of monogenic diabetes, diseases of exocrine pancreas like pancreatitis or any trauma to the pancreas can cause diabetes. Endocrinopathies like Cushing's syndrome or acromegaly can definitely lead to diabetes. Drug-induced, especially kids taking beta blockers or more commonly any anti-epileptics, can cause increased blood sugars, and infections that are closely related to secondary type of diabetes include congenital rubella, enterovirus, and CMV, which have been established. A quick tabulated view on the clinical characteristics of type 1 and type 2 diabetes in children. They are both polygenic in inheritance, type 1 and type 2. The age of onset, usually type 1 presents after the age of 6 to 12 months, whereas type 2 usually presents later on after the age of 10. The progression of type 1 is acute and rapid, and they can actually land up, 70% of them actually land up with DKA by the time they realize it was diabetes. Type 2 is variable. You could pick it up early with acanthosis nigricans. Autoimmunity, definitely in type 1. You have GAD65, anti-insulin, zinc 8, etc. antibodies. So it is an autoimmune phenomenon. However, antibodies are negative in type 2 diabetes. Ketosis is common in type 1. It could happen in type 2 as well, but it is rare. Obesity definitely is a predisposing factor for increased frequency of type 2 diabetes, as already mentioned. Acanthosis nigricans, which are the black velvety patches you see at the nape of the neck, underarms, and the groin folds, have got to do with insulin resistance. And that's a kind of a clinical marker for type 2 diabetes. The frequency of type 1 diabetes in children is more than 90%, and type 2 is on the rise. These statistics may actually change after a couple of years if the obesity epidemic does not get controlled in developing countries. And family history is seen only 2 to 4% of type 1, whereas more than 80% of type 2, there is a strong familial inheritance seen in there. Now, what's monogenic diabetes? This is a very interesting form of genetic diabetes that you can pick up in children, and it is monogenic in inheritance. The age of onset is often post-pubertal, except for MODY2 and neonatal diabetes, which you can pick up in less than 6 months of age. The progression is variable. There is no autoimmunity. Ketosis is rare. Obesity is as good as the one that is seen in the population. No acanthosis nigricans. Family history is highly positive. Almost 90% of them will have a family history, especially an autosomal dominant type of inheritance that you can see in MODY. A quick look at the diagnostic criteria for diabetes in children and adolescents. The classic symptoms of diabetes are hyperglycemic crisis with a plasma glucose of more than 200 milligram per deciliter is important if you take a random blood glucose. Fasting plasma glucose of more than 126 milligram per deciliter, a 2-hour post-load of more than 200 milligram per deciliter during an OGTT, and HbA1c of more than 6.5%. Here, an important thing that I need to discuss is that HbA1c should not be taken as a standalone criteria for diagnosis in pediatric diabetes, and you must confirm it with an oral GTT to see whether there is diabetes or not. If some kid comes to you with the symptoms that I've mentioned and you do a fasting plasma glucose, this is how you can interpret it. If it is less than 100, it is normal. If it is 100 to 125, it is impaired fasting glucose. And more than 126, you can easily say that it could be a provisional diagnosis of diabetes, and you need to confirm it with an oral GTT. And when you give 1.5 gram per kilogram of oral glucose, that's the dose that you give in kids, a 2-hour post-load glucose of less than 140 will be normal. If it is between 140 and 200, it is impaired glucose tolerance, and 2-hour post-load glucose of more than 200 milligram per deciliter gives us the diagnosis of diabetes. A quick overview on the management. Suppose a kid comes to you, how do you manage type 1 diabetes? So you need to replace insulin in the best possible physiological way and optimize the glycemic control so that we can reduce the development of micro and macrovascular complications that can eventually occur. So you need to understand that the basal bolus regime is the standard of care for pediatric diabetes. There is very limited role of pre-mixed insulins. You just cannot manage their HbA1cs, their diet, and the flexibility with pre-mixed insulins or even with a regular insulin. The standard of care now includes rapid-acting insulin analogs like lisproglulisine and aspart, and a long-acting insulin analog like insulin glargine or degludec, that is the recent one that has been approved in children more than 2 years of age. So multiple daily injections with a rapid-acting analog before meal, that is around 5 to 10 minutes prior, along with a long-acting basal insulin, is now the standard of care in type 1 diabetes. Now, this is an area of intense research, and lots of technological advancements are happening in children with diabetes. And the most important one that we are seeing in the last decade is the continuous glucose monitors, the CGM, which is just put on over here, as you can see, and you have a sensor to read the data. And now improved methods of monitoring like time in range, TIR, is interpreted. And these are the types of graphs you get with CGM. So these are path-breaking technologies for management of diabetes in children, where you can do away with the self-monitoring of blood glucose glucometer pricks. And another breakthrough is CSII, that is insulin pump. As you can see, this pager-like device, and that is connected with a small tubing, to a sensor which is there. And by Bluetooth, you have a CGM connected there, and that gives you the blood glucose levels, as well as you have the insulin that you can continuously give through an insulin pump. So you can do away even with the multiple daily injections. The only problem with these technologies are they are cost prohibitive, extremely expensive. But for those who can afford these AI incorporated technologies of insulin pumps, it is definitely a breakthrough for many of them to give them a kind of a good HbA1c so that the complications that eventually happen can be postponed. The last part of my lecture would be that diabetes definitely comes to us with emergencies, and there are two important emergencies that can happen in children. A quick case scenario, a 7-year-old girl came with complaints of vomiting and abdominal pain since one day. And when we went ahead to ask them, we could figure out that there was polydipsia and nocturia since 15 days. There was weight loss of 2 kilos over the last 2 months, and these were her vital signs. She was drowsy. The respiratory and abdominal system examination was normal. Her weight was around 20 kilos. So we assessed her and found there was tachypnea, tachycardia. She was sleepy, moderately dehydrated. And please do remember, after ABC of resuscitation, DEFG. So it goes on. Don't ever forget glucose. The BSL on glucometer was taken. The urine ketones should be done if BSL was more than 200. Blood ketones is another thing that you can do if available. You should do an ABG. A full blood count and serum electrolytes. This is the workup to be done if you're suspecting DKA. And you should insert 2 peripheral IV lines and manage them in the PICU. And these were the lab results that came in. As you can see, the BSL was 480, pH was 7.1, low bicarb of 6.2. The urine ketones were large and the electrolytes were normal. So this is DKA, and the biochemical criteria for the diagnosis of diabetic ketoacidosis is hyperglycemia, that is blood glucose more than 200, venous pH less than 7.3 or bicarb less than 15, along with ketonuria and ketonemia. So DKA is a salvageable condition. If you do not treat it, it can go on to have some morbidities due to cerebral edema and even carries a risk of mortality. So please be very careful with any child who comes to you with respiratory distress or any of the above symptoms. And another emergency that they can present with is a similar case. A 7-year-old boy comes to the ER in a drowsy state. He also complains of polyuria and polydipsia. He looks well nourished. Weight is 36 kg. You do the BSL, it was 620 milligram per deciliter. However, he did not have any signs of dehydration until then. These were the vital signs, which were, except for a bit of tachycardia, the rest were okay. And the systemic examination was normal. So again, we need to proceed with the same labs that I mentioned before. The BSL is 620. When we did the urine ketones, they were absent or trace. The pH was normal, bicarb was okay, more than 15. However, the effective serum osmolarity was 340, which was very high. And this diagnosis, if you get something like this, always think of another emergency called a hyperglycemic hyperosmolar state. So a hyperglycemic hyperosmolar state, or HHS, the criteria for diagnosis is plasma glucose more than 600, a venous pH more than 7.25, bicarb more than 15, small ketonuria absent to mild ketonemia, effective serum osmolarity more than 320, and any altered consciousness or seizures. Please think of this condition. So overall, you're never too young to have diabetes. It can start right from the newborn period and continue till the time you are alive. So let's try to do our best to manage this condition well in children. And if you ever have any doubts, please feel free to connect with me. This is my email ID. We would be happy to work with all of you. Thank you very much for your attention.
Thank you, ma'am, for such a good lecture on the diabetes and approach to children. Anyone, any questions?
Can I ask something?
Yes,
Mr. Chawla? Yeah. Actually, of course, we have not worked much with diabetic patients as of now. We're just starting to work on them, and children definitely, we have not yet, I can say that we are not really started. So little bit of query about exercise. Of course, we are going to cover that later on, but still, because the topic is related to pediatric. So a little bit of study says that for preschoolers, you should have 60 minutes of activity per day. And you should give your child 5 to 15 grams of carbohydrate for every 30 minutes of activity, depending upon the initial blood sugar levels and intensity of exercise. And for young children and adolescents, again, we can include all kinds of aerobic activities, but it is little difficult for children to give them exercise or the balance between the activities and their insulin and the entire management, because child is so active and timings will be different. So how do you explain about it, how to go about this? Very challenging for children to manage.
Certainly. See, pediatric diabetes is a very, very challenging field. We deal with all kinds of permutations and combinations, especially when they start going to school. That's another story altogether, how to adjust their insulin and exercise, etc. But regarding the exercise regime, if they are going in for some intensive exercise or they're going in for some physical activity in school, we always recommend to them to take an extra carbohydrate exchange, okay, either a fruit or something like that before they start any exercise. So that is one way of doing with it, okay. But exercise also is seen in the long run to kind of normalize the blood sugars and to decrease the HbA1c, whatever. So just a regular play or running around for 60 minutes a day in the evening is what I usually practically recommend to most of my patients. And they do pretty well. But type 2 diabetes, which is on the rise, Dr. Smita, that will be a very big challenge for even the physiotherapists like you to handle, because your play comes most in that for them to reduce their weight. Once you reduce their weight, we can reverse their diabetes. So that's most important.
Yeah, we'll definitely look forward to it and we'll work on that.
Sure.
Yeah. Thank you.
Thanks.
Any other question?
So Dr. Sujit has asked me how to decide the dose of insulin. Actually, Dr. Sujit, it was beyond the scope for me to cover each and everything in 20 minutes because pediatric diabetes is such a vast topic. But it is usually this way that pre-pubertal kids, we start at 0.7 units per kg. When they enter puberty, because of the sex steroid levels being so high, we increase it to around 1 unit per kg, and post-pubertal 1.1 to 1.2 unit per kg may be required. And out of that, almost 30 to 40% is given as a basal insulin, and the rest of the 60 to 70% we equally divide as a rapid-acting insulin analog before breakfast, lunch, and dinner. And also sometimes you need to give an extra dose during tea time because probably the RAI, rapid-acting analog, will not cover the tea time snacks. So that is how we generally manage the dose of insulin. So Dr. Prashant, is there any recent guidelines for treatment of diabetes in the pediatric age group? Yes, doctor. There are definitely guidelines for treatment of diabetes by ISPAD, our International Society of Pediatric and Adolescent Diabetes, has published their last guidelines in 2018. They are free to download and free to read. And they also recommend the same basal bolus regime as the standard of care, in which includes a rapid-acting insulin analog for the increased flexibility of the use of RAIs in children, and also basal insulins that are used. So definitely the recent guidelines to be followed are those of ISPAD. I would be happy to answer any other questions. Otherwise, maybe Harshal, my colleague Dr. Harshal, would take over for the next lecture. Thank you very much, Dr. Ritu. And
thank you, ma'am, for patiently answering the questions.
Thank you so much. Yeah.
Now moving on to our next speaker, Dr. Harshal Ekatpure. He is a consultant endocrinologist and diabetologist in Ruby Hall Clinic. He is having special interest in obesity, diabetes, thyroid disorders, reproductive issues, osteoporosis, parathyroid, and other bone disorders. He will be giving a lecture on glucose monitoring, importance and implications. So over to you, sir.
Yeah. Thank you, Ritu, for the introduction, and good morning on a fine Sunday morning. Let us talk about the glycemic monitoring, importance and implications. Now you are diagnosed the patient with diabetes, beta type 1, type 2, and after diagnosis, the real task begins, and that task is of a monitoring. And when we think of glycemic monitoring, there are plenty of questions, not even in patient's mind, but also in a caregiver or a practitioner's mind. When, how to, how frequent, why, in type 1, GDM, type 2, how to monitor, how frequently to monitor. So basically what blood glucose monitoring is, that you are checking the blood glucose levels with the help of a device called as a glucometer. And the purpose is that patient should be aware of their blood glucose level, how high or how low it is, and individual blood glucose pattern or individual blood glucose changes that patient and practitioner should be aware of. That data we want to get with the monitoring. So with monitoring, what we are actually achieving is we are reducing the risk of complications associated with diabetes by addressing the certain blood glucose fluctuation. Patient should know that treatment is working, because most of the patients are asymptomatic and they are taking medications but not feeling any difference. So when they monitor, they feel that the treatment is working, I am under good control. That gives them confidence. Exercise and food on a blood glucose levels. Whenever patient sees the impact of exercise or impact of bad food on their blood glucose levels, it acts as a kind of motivation for them to do a lifestyle changes in their routines. And hypoglycemia, hyperglycemia, of course, that is the primary thing that we want to prevent by uh, asking the patient to monitor the blood glucose levels more frequently. So when to check the blood glucose levels? Of course, fasting is the time. That is the most common reading. Most of the patients take it. Before meals readings, pre-meals readings are also important in some scenarios. 1 hour or 2 hour post-meal readings, 1 hour especially important in the patients with GDM, some cases of type 1 diabetes. Usually type 1 diabetic patients, these additional monitorings are required. That is 15 minutes before and after physical activity or before bed. And in hospitalized patient, we usually do the pre-meal sugars or pre-meal blood glucose levels, and sometimes 2 hourly, 3 hourly or more intense monitoring is required in a critical care setup also. So when we monitor the blood glucose levels with the glucometer, it has its own limitations. Of course, the patient-related limitations are far more predominant, especially elderly and children cannot deal with the complexity of the glucometer devices. Cost is there. Then every time you have to prick yourself, so painful. It's painful. Most of the time, children deny pricking themselves on a multiple occasions, and consistency-wise, that's why it is very low in long run. Device related, now you see, as in a country like India, anybody can manufacture everything. So there are n number of manufacturers for glucometers. So there is a quality control issues, shelf life issues, strips get malfunctions if they are exposed to very humid or very hot conditions, and accuracy and precision problems are the common stay of a glucometer. And when we are using it in a special situations like uremic patients, hyperbilirubinemia patients, hypertriglyceridemic patients, definitely the accuracy goes down or accuracy fluctuates. So reproducibility is not usually there when special circumstances. So what is the answer for this? Usually the newer technology, like Dr. Meghna has already touched upon it, the continuous glucose monitoring system, where there is a sensor which sits on your body, particularly on the arm, and the sensor is usually situated in the interstitial fluid, and usually the interstitial fluid glucose and blood glucose levels are in synchrony or in equilibrium. So you can say that interstitial blood glucose level is sensed by that sensor and it is reflected on a device. So it has a kind of continuous glucose monitoring system, and this is how it looks like. The sensor sits on your arm, it monitors the or measures the blood glucose levels, and it can remain there for 14 days. Now, what is the utility of this CGM system? I would like to put forth a example. This is typically 58-year-old diabetes since 10 years on 2 grams of metformin glimepiride, asymptomatic presently, but every time he comes for follow-up, fasting used to be around normal range, postprandial around 144, but HbA1c is 9.1. So last time we saw this patient, we asked him to repeat from our lab. Again, same readings, 118 fasting, 135, A1C is 8.9. So elevated HbA1c and fasting PP under normal, appears to be under control. So what to do next? So traditionally, these patients, we ask for a 7-point blood glucose profile, fasting, post-breakfast, pre-lunch, post-lunch, pre-dinner, post-dinner, and sometimes at bedtime or a 3 a.m. sugars to see which blood glucose level is going up. But it is very cumbersome for these patients and they have to go on with their routine life. So it is not possible to check on a multiple occasions. So this second option, newer option of a continuous glucose monitoring system, which measures the continuously from the interstitial fluid like I have described. So we applied the CGM for these particular patients, and those were the results. So patient was checking the fasting plasma glucose, which was appearing normal. He was taking the post-lunch sugar, which was appearing normal, but there has been 2 spikes which has been unaddressed. Like you can see the post-breakfast spike and the post-dinner spike. And these 2 spikes were never measured in this particular patient, and that definitely contributed in the elevated HbA1c in this patient. So this is something called as a glycemic variability that we'll see in subsequent slides. And this gives you the detailed line diagram about each and every day's blood glucose levels. And as you can see how patients are having fluctuating blood glucose levels on particular days, especially on the weekends, their blood glucose levels can go haywire. And on those days, usually patients are not checking their blood glucose levels on a monitor. And you can the graph also gives you the median blood glucose level of a patient. So a fasting PP may appear normal, but there are glycemic variations or excursions elsewhere. So features of this CGM is, of course, it is relatively painless, non-cumbersome. Once it is applied 14 days, it can record the data. Fairly accurate unless in certain edematous condition or a CKD, CLD condition, and records the blood glucose level for 14 days. Patient just has to keep a food diary and write down the whatever things he or she is eating and the insulin doses that patient has been administering if it is a type 1 diabetes. Cost was the issue so far, but now it has been available at very cheaper rates. Some companies are giving it as a free of cost also to certain patients. So from SMBG to CGM in terms of glucose monitoring, we are experiencing this transition journey or a new era of a journey, you can say, where the traditional SMBG might miss some points of hyperglycemia or most of the points of hyperglycemia, as you can see from the slide on left. And when you connect the dots, the CGM can actually give you the blood glucose levels which are fluctuating in a very high amplitudes. So usually HbA1c most of the times does it tells us the real story. Most of the times in 80% of the patient, yes, you can say HbA1c is fairly okay, but there are this 20-30% of population where, like you can see from the left hand side, the HbA1c around 7.6 to 7.7, but you can see the glycemic fluctuations in these 4 individuals. Some of them are spiking post lunch, some of them are spiking post dinner. So they are not very smoothly controlled, you can say. Similarly, though those set of individuals, though having same HbA1c 7.7, their glycemic pattern may not be similar. One person might exhibit a very severe degree of glycemic excursions, peaks and troughs, and so other person might have a very smooth profile of a glycemia. So this is somewhat called as a glycemic variability, and that has given this newer concept or rise to a newer concept, which is called as a time in range. Time in range means the amount of time or a percentage of time in a 24 hours the patient is spending in a given glucose range. Broadly, you can say in a normal individual, this range could be around 80 to 180 in a type 2 diabetic patient. So amount of time patient is spending in that range, amount of time patient is above range, and that is time above range, and amount of time patient is below range, that is a time below range. So our aim is to not only normalize HbA1c, along with HbA1c, we should increase the patient's time in range. The percentage of the readings taken in a 24 hours time should be within the range. And this primary goal for effective and safe glucose control is to increase the time in range and reduce the time above range. That is the relatively newer concept. And that's why the standard bodies are also recommending. ADA 2019 consensus has stated that time in range is the newer metric of a glycemic control, and it provides more actionable information than HbA1c alone. So you can actually see the glycemic excursion, peaks and troughs, and then act accordingly or tailor the treatment accordingly to increase the time in range. And it is recommended to have a 70% or more time in a range in most of the type 1 or type 2 diabetic patients. So in general, when you are talking about type 1 diabetes and type 2 diabetes, the consensus guidelines are more than 70% time in range and less than 20% time above range. Older who are high risk type 1 diabetes or type 2 diabetes with multiple comorbidities like chronic kidney disease or presence of underlying heart failure, cardiac condition, very high risk of hypoglycemia. In these patients, you can actually target in time in range is around 50%. Time above range, that is up to 180, between below 50%. So you can relax the target in these patients. In pregnancy, type 1 diabetes, again 70% time in range. Gestational diabetes, type 2, try to maintain the time in range somewhere around 80 to 85%. And does it really have any implication as far as the diabetic complications are concerned? And the answer is yes. For every 10% lower time in range, there is retinopathy risk, which has gone up by 64%, microalbuminemia risk, which has been increased by 40%. So time in range, as it diminishes, the risk for retinopathy and nephropathy definitely goes up. Similarly, for a macrovascular complication, this is the data from a Chinese study where if there is a smoother glycemic control, or if you increase the time in range by more than 10%, it is associated with 6.4% lower risk of abnormal carotid intima media thickness, which is the indirect marker of vascular events. So intima media thickness also goes down when you control the patient in a better manner in terms of time in range. So many guidelines, including the international consensus, ADA, EASD, are now recommending more and more in terms of continuous glucose monitoring systems. What we can actually assess with continuous glucose monitoring systems is, of course, you can devise a patient-centric plan, and that is more important. Once you get to know the pattern of patient's glycemic variations, you can devise the patient-centric treatment plan, monitor the hypoglycemias, particularly in hypoglycemia unawareness patients, nocturnal hypoglycemias you can detect with the CGM. Glycemic variability assessment, peaks and troughs you can address in a better manner. Factors which can impact the blood glucose, diet, exercises, lifestyle changes that can be identified, and postprandial hyperglycemias can be better controlled when you can actually see after which meal it is going very high or very low. So in type 1 diabetic adult patient, it is definitely recommended to monitor with the CGM and adjust the dosage of insulins accordingly. Pediatric patients also, it is strongly recommended because pediatric pattern of eating and insulin administration is very fluctuating, or you can say very variable. Patients who are on insulin sulfonylurea, again, strong recommendation for CGM. Type 2 diabetics on a routine care, as per physician's discretion, if at all you want, you can use. GDM utility or accuracy has not been established till that beyond doubt. So we need more data in the patients with gestational diabetes mellitus so that we can advocate the use of CGM system in a gestational diabetic patients. And as you can see, it is very has a very wider application. Even in the children, it can be applied very easily, and we have a device on which you can see the real-time blood glucose levels, and clinical benefits are of course apparent by increasing time in range and reduces the risk of hypoglycemia. So for monitoring purposes, glucometer and CGM are relatively the newer technologies. Some are the alternate technologies which I'll just have a brush upon before ending. So it is the alternate site glucometer testing. The patients particularly who have problems with their peripheral appendages like fingers and toes because of a number of reasons, sometimes burn, sometimes vitiligo, because of the peripheral vascular disease associated with the diabetes. Sometimes it is very painful to check it on the fingers or toes. So these alternate site glucometers are slightly less painful as compared to the traditional glucometers, and upper arm, forearms or thighs, hand samples can be taken for the blood glucose monitoring. Similarly, nowadays it's a era of a smart watch, so that's why there are this GlucoWatch biographer which can actually detect the blood glucose levels from your veins or the capillaries which are flowing underneath it. But accuracy yet has to be established beyond certain doubt. Similarly, silicone microneedles are there which are relatively painless, which can detect the blood glucose level similarly as a CGM systems. Glucose monitoring system, Dr. Meghna has touched upon it, where there is a sensor and there is an insulin pump, and they have been connected via Bluetooth technology, and all through the app which is on the patient's cell phone, and patient can actually see the real-time reading. And with the newer pumps can actually administer the insulin based on the blood glucose level as per the preset algorithm. So we are very near to closing the loop with the help of these newer technologies like CGM, insulin pumps, and the artificial intelligence. So take home messages: glycemic monitoring, of course, crucial part of any diabetes management. The CGM systems are very easier, convenient options for glycemic control. And time in range is relatively newer and useful concept, but has to be interpreted along with the HbA1c. Till now, it has not replaced HbA1c as a metrics of a glycemic control, but definitely it is a metrics of a glycemic control, and it has to be interpreted along with the HbA1c. So with that, I thank you all, and if at all any questions, will be more than happy to answer.
Thank you, sir, for sharing some new insights on monitoring of glucose. Any questions?
Dr. Harshal, can I ask you one question? Yeah. Sir, I want to know about how intensive should be a blood sugar control in a mainly ACS patients. How intensively we should control them?
So acute coronary event patients, actually, when at the time of hospitalization, there is of course a reactionary hyperglycemia. So at the initial 24 hours till the time everything settles down, it is better to put a patient on an infusion. And ideally, we try to keep the blood glucose levels below 180. We monitor more frequently, 1 hourly or 2 hourly, and 140 to 180 is the initial target range. Later on, as the patient settles down, then we have to individualize the target. Like suppose it is a really young patient, 45-year-old male, first episode of acute coronary event, and he's recovering well. Of course, I will go for a very tighter control in hospital settings. Premise blood glucose, I will try to keep it below 140, and in long term, my HbA1c goal between 6.5 to 7%. On the other hand, elderly patient, maybe triple vessel disease, surgery not feasible. In those patients, again, you have to individualize HbA1c around 7 to 7.5 you can target for that patient. And in hospital also, the broader range, you can say around 80 to 180 is more acceptable range. But definitely the hypoglycemia has to be prevented at all cost in these elderly patients.
So is there any role of insulin glucose therapy in acute coronary syndrome? I mean, is it helpful for stabilization of myocardium? Because some people use that, some people don't use that. So I think it's not studied in trials.
One school of thought regarding this, I think because of the myocardium, the natural fuel is alternate fuel. So there is one school of thought, but the definitive evidence as such in terms of long-term survival or outcomes which are better, I think that is still lacking in terms of infusion therapy. So we might need more studies on that.
So Abhijit, I think you're referring to the Digami trial, and from the Digami trial, this actually comes they had the Digami 1 and the Digami 2 trials. And in the Digami trial, what they actually used was intensive glucose control. But even in normal individuals, they looked at the possibility that can you give glucose, insulin, and potassium infusions. That was the actual trial that they used, and to see the outcomes in these patients post discharge. But what actually worked well, as Harshal just said, was that the intense control should not be at the cost of hypoglycemia, because hypoglycemia can precipitate dangerous arrhythmias. And most of the mortality that actually happens is because of arrhythmias rather than anything else. And the Digami 2 was actually a step ahead from the Digami 1 trial that they did. And they showed that, yes, post-discharge, if you had kept the patients between 140 to 180, then their overall, readmission rates for any cardiac events were low, and they had a better revascularization in the future. So, I mean, there is a definite case for good control, but not intensive enough to cause hypoglycemia. Then you have to monitor them very frequently. So the glucose, insulin, potassium infusions, we had done that in Ruby Hall in our initial years to see the impact. And there was actually a trial that we used to run in Ruby Hall for it with the cardiologist. And we really didn't find too much of benefit. In fact, the patients kept going into hypos, and we had to then stop the trial also.
Okay.
I don't know if you're talking about, CGMs. I don't know if you've read the latest paper that Eversense has now come out with data, and they've shown that CGM up to 180 days, they've shown a good, stable monitoring with a fairly linearity to the, blood glucose, venous glucose estimations. So they've just put out the data Eversense CGMs that up to 180 days that you can do a continuous monitoring, which is going to be actually very good. Then, you don't have to really, change the sensors very frequently.
There are some questions in the chat box. Manoj, could HbA1c be high with normal fasting blood sugars, and postprandial blood sugars in a patient with no previous history of diabetes?
Yeah, there are two aspects to it. One is if HbA1c is persistently high and your fasting PP is normal, first means rule out the diabetes by doing the 75 gram oral glucose tolerance test. But if you strongly suspect that there are some abnormalities in terms of hemoglobinopathies which are apparent in the CBC report, so hemoglobinopathies can also give rise to falsely high HbA1c in those particular patients. So two things: one, rule out with the 75 gram OGTT whether patient has a diabetes or not, or you can apply the CGM and see whether the sugars are really going high. And second thing is the assay related interferences, hemoglobinopathies, whether it is giving rise to falsely high HbA1c levels. Second question is also there: in diabetes patient, nephropathy with hypertension, which control is more important, sugars or blood pressure? Of course, both the controls are important. Hypertension or blood pressure control with much more predominant. In a glycemic control, we just want, once patient has established nephropathy, like you are talking about the end-stage renal disease or EGFR below 45, in those patients, we just want to attain a stable glycemia in this patient. What we want to prevent is a glycemic excursions or a troughs. So in these patients who are really fragile with end-stage renal disease or CKD stage 3, we usually go for this type of pattern, the glycemic control in a range and prevent the hypos and hyperglycemias. Those who are above 45 fairly stable, of course, we take the help of SGLT2 inhibitors, which are shown benefit in terms of kidney outcomes in the long term, and target the HbA1c around 7%.
Okay. Thank you so much, sir, for some good points on glucose monitoring. Let's move on to another topic. Other speaker is Dr. Sanjay Agrawal. He is a renowned physician from Pune dedicated to the treatment of diabetic patients. Currently, he is the head of internal medicine in Ruby Hall Clinic, Pune. He'll be speaking on choosing the right therapy for patients with type 2 diabetes.
Thank you, Ritu, and thank you for this wonderful, your presence on this update. I'm sure the previous lectures have been very enlightening, and I'm just going to move on because with all the plethora of treatments that we have available today, the challenge is to choose the right therapy for the right patient. And let me make the opening statement that almost about 30% of patients with diabetes are 65 years old or older. More than 50% of our patients are overweight or obese, and 65% of the deaths in diabetes are caused by cardiovascular disease, and almost 40% of our patients have concomitant kidney disease. So with this background that we've got, I'm sure it is rather challenging to choose the right therapy for an individual patient. While there have been very steady, introduction of antihypertensive agents over from 1950 onwards till date, there has been a sudden glut. So people like me who have actually started very early in practice, we earlier had only our conventional insulin, that was animal insulins, sulfonylureas, bigonides, which were earlier the ones that we used were fenformin and then metformin, of course. And these were just the earlier treatments. And then over a period of time, there has been a sudden escalation in the amount of drugs that we have and a lot of sophisticated drugs which work at different levels. So today, it is extremely difficult to keep a patient uncontrolled if you're using the right principles of management for diabetes. Now, this is an excellent the algorithm that was put out by Silvio Nzucci for the ADA. And he sort of portrayed that what would be the patient characteristics that influence judgment of treatment of hyperglycemia. And these were some of the parameters like patient attitudes, potentially risk for hypoglycemia, disease duration, life expectancy, important comorbidities, established vascular complications, resource and support systems. And on one end, you had patients who were the right patients who would need more stringent control and who were the patients that required less stringent control. And there was a whole bit that, okay, patients who were, early onset, young patients, they would probably require a more stringent control. Whereas patients who are older, had disease duration for a longer period of time, having various comorbidities, probably you need to let them go a little loose. But it's never so easy, because while it would be very easy to structure treatment if everybody was on one end of the graph, or on this end of the graph. But in practice, you find that there is a whole mixed variability that the patient comes to us because they present very heterogeneously. And you need to make your decision that what is really the priority in terms of your treatment. So having said this, earlier our approach would be just control the fasting plasma, post-meal plasma glucose and the HbA1c, and you're happy with that. The later metrics that we now look at is, do we need to reduce the glycemic variability, assure that we'll have low incidences of hypoglycemia and weight gain, and in turn, we need to give a better quality of life for our patients. So we now, of course, come to a glycemic composite where we are looking at all these parameters put together in an individual patient so that we are getting him an adequate glycemic control, but with a lower risk of hypoglycemia, weight gain, and a lower variability so that he can enjoy a better quality of life. We are different as an Indian, and we know that we have a high insulin resistance, strong family history. We present early in life. We have an early onset of cardiovascular disease and other complications. We tend to have a more carb-rich diet, sedentary life. And as has been termed, the coined term by Dr. Yagnik, that we are thin fat Indians, where the phenotypically we may be thin, but we are metabolically fat. And all these lead to early beta cell dysfunction. So we need to address our glycemic goals very aggressively. And it is sad to see that only about 57% of our patients actually test blood glucose, and less than 20% are actually reaching the composite glycemic goals. Or when you look at the entire composite of blood pressure, lipids, blood sugars, all of them are even dismally lower than that. Now I'm going to show you the heterogeneity. For the same almost glycemic values, patients present differently. So here's a 32-year-old male working in an IT company, diabetic for 3 years, strong family history, patient is asymptomatic, mild hypertension of 140/100, BMI is 36, having a fasting plasma glucose of 200, PP of 240, A1C of 7.8, has acanthosis. And currently his medications are, he's only on metformin 2 grams a day, along with lifestyle modification. So clearly the goals are very outlined, that you want to see that you get the weight control, you get glycemic control, and you're obviously targeting even the blood pressures. And rightfully, the approach should be more towards an aggressive lifestyle with, of course, insulin sensitizers. That should be the goal. So your choice of medications are going to be weight reduction, drugs that will cause weight reduction in parallel to glycemic lowering. Now, here's another case where almost similar glycemic values of fasting 180, post-meal of 240, and A1C of 7.8. But this is a 48-year-old gentleman, diabetic for 8 years, having a history of nephropathy and retinopathy for 3 years, has swelling of legs, has shortness of breath on minimal walk. He notices a fall in urine output, has severe hypertension with 200/100, BMI of 28, has edema and pallor, and his GFR is 24 with a creatinine of 5. His current medication, he's on a pre-mix 88, pioglitazone 30, glimepiride 4 milligrams per day, and metformin 1 gram. So he's obviously a patient who's got multiple comorbidities. You can see that he's got hyperglycemia, he's got nephropathy, retinopathy, and he's probably moving towards an end-stage kidney disease gradually with the severe hypertension. And maybe there could be a concomitant congestive heart failure that could be present here. Now, if you look at the choice of medication this patient has, he's definitely aiming for trouble. And you have to probably reduce most of his medications, cut off the pioglitazone, cut off the metformin. You have to see this patient for glycemic variability and episodes of asymptomatic hypoglycemia. And I would be very happy to keep this patient slightly loose in terms of a higher A1C in interest of safety. So your choice of medications are going to be a little different for these patients. And here's another case where almost similar glycemic values of fasting of 150, post-meal of 200, and A1C of 7.6. But this is a 45-year-old male diabetic for 7 years, has associated hypertension and obesity, smoker, alcohol consumption of 2 pegs 4 times a week, has a weight of 96, blood pressure of 150/96, of 220, sedentary life, albumin creatinine ratio 120, creatinine 1.4, has a positive treadmill, and currently is on amlodipine, metformin, and glimepiride. So clearly you can see over here that this patient has extremely high cardiovascular risk factors for getting into a cardiac event. And unless we aggressively manage his entire consortium of risk factors, this patient is heading for cardiac trouble. And you can see here that this is another class of patient that we see in routine practice. So I've just illustrated to you 3 cases, similar glycemic values, and yet presenting to you in very different formats. So obviously, you can't have a tailor-made treatment which fits everybody. You have to individualize goals. And this is an excellent sort of slide that I always love to show. And how do you evaluate and assess comorbidities? And this is from the ADA guidelines of 2022, where you need to look at the key patient characteristics, look at the lifestyle comorbidities, the clinical characteristics, motivation, and cultural, socioeconomic. You look at, of course, specific factors which will impact the choice of treatment. So A1Cs, weight, hypoglycemia, side effect profile, the choice of complexity. And then, of course, in a country like ours, you need to have a cost consideration, which will, make sure that the patient is compliant to treatment. You need to share decision-making with the patient and involve the caregivers or the family. And you need to agree on a smart goal management platform where it is specific, measurable, achievable, realistic, and time-limited. You need to meet the patient. You need to have a team-based approach where you have a team in your, in your setup, which will sort of ensure that the patient understands your management goals. And you need to keep reassessing the goals to see how much of it he has achieved. As Dr. Harshal just mentioned in his talk, we need to do an ongoing monitoring and support so that the patient can manage his diabetes. We want to see that our patients are educated enough to do a self-management. And you need to keep reviewing your management goals, mutually agree on changes, and ensure an agreed modification. Decision cycle should be taken periodically so that you reassess to see that the patient is not uncontrolled or missing out on problems that he may really not recognize. We are quite familiar with all the drugs that we have got. And if you look at the A1C reduction, when they're given as a standalone single dose, you find that the earlier drugs like metformin, insulin sulfonylureas had an A1C reduction of 1 to 2%, depending, of course, on the baseline A1Cs. The newer agents are, of course, a little modest in terms of A1C reduction, but the advantage that the newer agents tend to have is that beyond glycemic lowering, they also have sort of benefits in other outcomes where comorbidities are concerned, as I'm going to talk to you a little later. I'm not going to really dwell too much on A1C because Harshal has just talked about it, but the 3 important questions that we need to ask every patient is, what should be the A1C for most people and why? Who should we be more aggressive with and why? And who should we be less aggressive with and why? And the reason why we need to do that is we need to prevent hypoglycemia and weight gain, because this is one of the most foremost reasons for poor adherence to therapy and weight gain. So as Harshal just mentioned, that patients who need an A1C of less than or equal to 6.5 are the patients who have no comorbidities, young, have early onset of diabetes, has a longer lifespan. Whereas you need a little looser control when it comes to limited life expectancy, functional dependency. Patients have comorbidities, have propensity for hypoglycemia or hypoglycemia unawareness. And the benefit of glycemia is the patient may not live enough to really see the benefit of, tight glycemic control. One of the most important things that we really need to address, and this is something that we don't start conversations with our patient, is all about weight management. In more than 50% of our patients, no BMI is measured. If BMI data is available, more than 70% of our obese patients are not diagnosed. And if obesity is diagnosed, more than 63% of our patients have no counseling. And we know that obesity is the mother of all non-communicable diseases. And as I just pointed out to you earlier, it is perhaps the most important driver for cardiovascular risk as well as for hyperglycemia. We have shown the benefit of more than or equal to 5% weight loss. You can see that it causes prevention of diabetes, better glycemic control, and overall improvement in other quality of life parameters and cardiovascular risk. If you achieve more than or equal to 10% weight loss, you get the earlier benefits along with sleep apnea benefit and diabetes remission. And if you have more than or equal to 15% of weight loss, you get all the earlier benefits and reduction in cardiovascular disease mortality and all-cause mortality. So you need to consider give small targets to your patient. Start with 5% and keep giving him higher targets till he's able to achieve more and more. You give him a big target and this patient is a failure right from the beginning. We talk about exercise, and I'm sure Smita is going to talk to you a little later all about exercise. I'm just going to make a passing reference that we need to start conversations about exercise, encourage more than or equal to 150 minutes of per week of moderate intense exercise. We need to see that they do endurance and resistance activities. And I'll let Smita talk about this a little while later in her talk. We need to put diet recommendations, and we're going to again have a nutritionist talking to us about it. So I'm not going to really go into the details, but we need to ensure that there is a calorie deficit of 500 to 750 calories per day. And we need to keep a balanced, healthy full diet with 50% to 55% of carbohydrates, less than or equal to 30% of fat, and 15% of protein. I'm going to draw your attention to the current ADA guidelines of 2022, where there have been very clear goals to say that, okay, start with lifestyle, metformin. We are also in conversation and discussion about should we start combination therapy earlier. That comes from the verified trial, which showed a benefit of early combination therapy. And then after that, if the patient, you need to assess for all the comorbidities, particularly the ASCVD. So you look at if you have patients with ASCVD, recommend independently of the baseline A1C, the targets. So if you have ASCVD, then your choice is either GLP-1 RA or SGLT2 with benefits. Or if the patient presents or has a risk for heart failure, then SGLT2 has proven to be of bigger benefit. And that comes from the pipes and pumps theory, where if you have a higher sort of risk for ASCVD, then GLP-1s are the choice. And if you have a high risk of heart failure, then perhaps SGLT2 inhibitors are the way to go. And for patients who are at having or at a risk for chronic kidney disease or nephropathy, clearly SGLT2 inhibitors have an edge over a GLP-1. So patients who do not adequately get control with SGLT2, then we need to move them along with that to GLP-1 analogs. And then, of course, glycemic goals can be met with other drugs. Where the risk of hypoglycemia is there, you need to use agents which will minimize the risk of hypoglycemia, like incretins, SGLT2 inhibitors, or TZDs. And if the patient is still above a target, then you can sort of use additional agents, but you need to monitor them more intensively. Where weight gain is a problem, as I mentioned earlier to you, you need to use drugs that will promote weight loss. And as of now, we have only choice of 2 agents which actually have a definite weight reduction. That's the GLP-1 RA and SGLT2 inhibitors. You have incretins, which are DPP-4 inhibitors, which are and metformin, which are weight neutral. And then, of course, you've got the secretagogues and insulin, which cause actually a weight gain to happen. And in a country like ours, where cost is a major consideration, you need to see that we use cost resource. But the advantage that we have that most of our drugs are generic, and because they're generic now, it is easier to have a wider choice of agents that we can use in a clinical practice beyond sulfonylurea, metformin, and TZDs. What I want to draw your attention is that all along we talk about tight glycemic control, and the benefit of glycemic control actually occurs more for microvascular events. If you want to bring down the incidence of macrovascular events, you have to look at the entire conundrum of all the cardiovascular risks. Genes we cannot change, but we can definitely alter the weight, the dyslipidemia, hypertension, and diagnose diabetes early, so that we can address all this even in the pre-diabetes phase. And a little while back, I had given a lecture on pre-diabetes and cardiovascular risk. So the risk for cardiovascular disease actually starts much earlier than the overt diagnosis of diabetes. And you need to see that you're looking at all these factors if you want to bring a reduction to the macrovascular events. The benefit of tight glycemic control where microvascular events is concerned takes time to occur, but that's where you are. So we shouldn't miss out on the glycemic legacy, the benefits of glycemic legacy, which may happen with tight glycemic control. As I said, the pillar of management of individual patient is not only just glycemia. You need to do blood pressure control, lipid control, and address the cardiovascular risk and kidney benefits. The evidence for metformin is cardiovascular. There's a weak cardiovascular evidence for benefit, and there's no kidney data. Sulfonylurea, there's neutral or on cardiovascular events and no kidney data again. DPP-4 inhibitors, neutral on cardiovascular events, and there's no kidney data except for linagliptin, which is neutral. Acarbose, cardiovascular and kidney data is neutral or no data at all. GLP-1s is positive for cardiovascular, positive for kidney data. And then, of course, the SGLT2 inhibitors, we are positive for cardiovascular and kidney data. So now we've got a lot of ongoing cardiovascular outcome trials which have looked at GLP-1, DPP-4 inhibitor, and SGLT2 inhibitors. For want of time, I'm not going to get into the discussion of each of these trials. But in broad summary, these are the various trials related to various DPP-4 inhibitors which have looked at the 3-point or 4-point MACE outcomes and secondary outcomes. And what you know that most of these trials have been neutral when it comes to 3-point MACE. There has been a slight statistically significant increase for hospitalization for heart failure in the SAVOR-TIMI, but all the others have been rather there's no increase. So where only saxagliptin, allogliptin is concerned, there has been some sort of signal of increased hospitalization for heart failure. When it comes to GLP-1, we have got a number of trials which have looked at 4-point MACE and expanded MACEs, and you can see clear benefit in the MACE outcomes, and there have been rather less benefit in terms of hospitalization for heart failure. And with the SGLT2 inhibitors, you see that these are all the different trials with different SGLT2 inhibitors. They've looked at the 3-point MACE, 4-point MACE, hospitalization for heart failure, the kidney outcome. And you can clearly see the benefits when it comes to 3-point MACE, hospitalization for heart failure, and mortality from cardiovascular disease, all-cause mortality. You look at the kidney outcomes and clearly you see the benefits overall. I'm just going to make a summary from the DAPA-CKD, where you see the 39% risk reduction for primary composite outcomes of more than or equal to 50% sustained decline in EGFR, end-stage kidney disease, renal or cardiovascular death, 44% risk reduction for renal composite outcomes, and 29% relative risk reduction for composite CV death or hospitalization for heart failure, and 31% relative risk reduction for all-cause mortality. The key question since SGLT2 inhibitors is generic in India, that should all Indians receive SGLT2 inhibitors? We know that there are 5 key benefits. It is fast acting. You get initial action right from day 1. There is a sustained and significant glucose lowering that we achieve. It causes weight loss and BP reduction. There's a flexibility of dosing that we can get with minimum chances of hypoglycemia, and they have been proven to have cardiovascular, renal, and other pleiotropic benefits. So as a race, I think we clearly have an edge. So we should ask ourselves today that why should our prescription should not have an SGLT2 inhibitors? Because today we have trials which have looked at use of SGLT2 benefits even in low GFR. So they've gone down as much as 20. And we're looking at even heart failure with preserved or reduced ejection fractions. So clearly there has been, and we are looking at patients who have diabetes and no diabetes, where the benefits of SGLT2 inhibitors have been noted. So clearly we need to really ask ourselves that should we miss out on an SGLT2 inhibitors in our prescription? So my final thoughts is weight loss is important. A1C targets should be individualized. Choice of therapy should be based on patient characteristics, cost to the patient, and personal preferences. You should minimize the risk of hypoglycemia, minimize the risk of weight gain. Combination therapy should be started early, and we should be periodically evaluating the benefits of our treatment. There has been clear outline of which agent should be used where today through various trials. And my final take-home message is treat the disease, not its symptom. Treat the patient, not his blood sugar, and rationalize data with common sense. Thank you very much for your patient listening.
Thank you so much, sir, for your enlightening lecture on treatment of diabetes. Any questions?
Sir, can I ask you if someone is not asking from the audience? Can
Go ahead, Smita.
Okay. Sir, just one question while your presentation was going on, one came to my mind. If in one of the case, if there is an increase in uric acid level for recently diagnosed diabetic person for last 2 years, who is on medication for metformin or and is Istamet, and if the HbA1c level is ranging from 6.2 to 6.37, which is getting under control from 7 to 6.3 to 6.2. So is it because of the diabetes, or is it because of the side effect of the medicine that the uric acid level has slightly increased?
No. So metformin and as well as DPP4 inhibitors do not really lead to hyperuricemia. So that's very clear that there is no really cause and effect relationship when it comes to these drugs causing hyperuricemia. So there are definite other drugs, for example, diuretics and other things. So if there is a concomitant drugs that you're using that causes hyperuricemia, we are talking about a different set of scenarios out there. But if you're talking about whether the anti-diabetic medications is causing a hyperuricemia, no, that's not. So you have to look at, if there is a high uric acid, why is it there? I mean, is it because of drugs, that other drugs that you're using? Is it because of other comorbidities? For example, the patient may be having a chronic kidney disease, and the hyperuricemia may be a reflection of the chronic kidney disease, and that's why you may be getting hyperuricemia. Is it because of diet related that the patient is getting hyperuricemia? So there could be other factor that's really causing the hyperuricemia to be present, which you need to identify. But control of hyperuricemia is important. I mean, there has been a clear now outline. We had just sort of had a national consortium meeting on hyperuricemia, and we had come out with a book that we wrote. So now the guidelines are very clear that if you have asymptomatic patients, then with no comorbidities, then uric acid more than 9 should be actually the cutoff point where you treat. If you have symptomatic hyperuricemia, then your cutoff point's at 7 that you actually need to treat. And in presence of comorbidities, probably you'd use 7 as a cutoff point. So this is what we have actually recommended for the Indian population in the consortium that we had, a national consortium of, where we met up with a group of cardiologists, nephrologists, and diabetologists in Delhi.
Thank you, sir. Thank you. Yeah.
There is one question from the audience. Can an obese comorbid patient who has recovered recently from pyelonephritis be started on SGLT2 inhibitors?
Okay, so basically the thing is, if there has been any urinary infections, you would probably hold on to any SGLT2 inhibitors till you have sufficient evidence of resolution of the pyelonephritis, because you can cause problems. You can get a recurrence, and you may end up with a chronic pyelonephritis in these patients. By and large, if the patient is getting recurrent pyelonephritis, it's a choice of agent that I would avoid completely as a class when you have other agents that you would give. Simple urinary tract infections, you can give as you treat the infection, you stop the SGLT2 inhibitors, but you can restart the SGLT2 inhibitors after 6 to 8 weeks once there's a total resolution of the infections. If there are instances where the patient would be at a high risk for urinary tract infections for various reasons, again, you would probably avoid, or where they have complex UTIs, you would tend to avoid using an SGLT2 inhibitors in these patients.
Any other questions?
I think, Ritu, you can move on if there are no questions to the next speaker.
Thank you very much, sir. Moving on to the other next lecture on the era of SGLT2 inhibitors by Dr. Piyush Lodha. Dr. Piyush Lodha is a consultant endocrinologist in Ruby Hall Clinic, has pursued DM in endocrinology with an excellent academic record, has a special focus on comprehensive diabetes care with expertise in diabetes technology, including continuous glucose monitoring and insulin pumps. He's having special interest in wide range of endocrine disorders like thyroid disorders, growth disturbances, PCOS, adrenal, pituitary, and bone disorders, and osteoporosis.
Yeah, thank you for the introduction. Good morning to everyone out there. As we all know, today with the advent of the CVOT trials with SGLT2 inhibitors, it's been called as the era of SGLT2 inhibitors, as its rampant use being considered in type 2 diabetes. So, as Sir has discussed the benefits of the SGLT2 inhibitors, I would like to highlight basically on the risk factors and concerns which are more predominant with SGLT2 inhibitors. So over next 15 to 20 minutes, I would be talking about SGLT2 inhibitors, and I would be covering it under physiology of glucose handling and SGLT2 inhibitors, its benefits and concerns with clinical use, SGLT2 inhibitors in different population settings, and position of SGLT2 inhibitors in the current guidelines. So, interestingly, the SGLT2 inhibitors have derived from apple tree roots, bark of the apple tree roots. It was discovered in 1835, and the component which was derived from this was later called as fluorescein. This is a brief physiology. Normally, 180 gram of glucose is being filtered through the glomerulus, out of which 90% of the glucose is being reabsorbed from S1 segment of the proximal tubule, and which is facilitated by SGLT2 inhibitors. And SGLT2 inhibitors is highly expressed in the first segment of proximal tubule of the kidneys. The rest of 10% is being absorbed from S3 segment of the proximal tubule, which is facilitated by other co-transporter labeled as SGLT1. Due to this absorption, there is minimal or no glucose excretion normally. This is a figure showing SGLT2 co-transporter, which transfers one sodium ion with one glucose ion down the electrochemical gradient, which is created by the sodium potassium ATPase pump. So whenever we are using SGLT2 inhibitors, the glucose and sodium won't be absorbed, leading to glycosuria and natriuresis. These are the renal SGLT2 levels in normal glucose level. In normal glucose tolerance people, the SGLT2 levels are very low as compared to type 2 diabetes. So basically, SGLT2 levels are increased, which is a maladaptive response due to increase in glucose levels. So these are the parameter changes in renal glucose handling in patients with type 2 diabetes. As we all know, there is increase in plasma glucose concentration, which leads to increased expression of SGLT2 levels, which is a maladaptive response, which leads to increased tubular glucose reabsorption. And also the renal threshold for type glucose excretion is increased in patients with type 2 diabetes. This is a figure showing where the SGLT2 inhibitors will be acting. Patients with type 2 diabetes, there is excess glucose being filtered from the glomerulus, and it is absorbed at the SGLT2 levels. As SGLT2 is overexpressed and also the threshold is increased, a big amount of glucose is being absorbed in type 2 diabetes. Now, what we are doing is we are blocking this SGLT2 transporter, so which will reduce the blood glucose levels due to less glucose reabsorption from the proximal segment of the renal tubule. So, as I mentioned prior, in kidneys due to SGLT2 inhibitors, there is increased glucose excretion and increased sodium excretion. So, there will be glycosuria and natriuresis. Due to glycosuria, there is reduction in fasting and postprandial glucose levels, thereby reducing a HbA1c by about 1%. And also there is loss of calories, which will cause a modest weight loss of around 2 to 3 kgs. And due to natriuresis, there is reduction in sodium load. So there is reduction in blood pressure levels by approximately 3 to 5 mmHg. So these are other benefits which have been shown with SGLT2 inhibitors. Now, SGLT2 inhibitors as anti-diabetic agents, there is inhibition of SGLT2 pump. So it provides a non-insulin dependent mechanism to reduce the glucose levels. And these drugs have been approved since 2013, and currently available approved drugs are canagliflozin, dapagliflozin, empagliflozin, and ertugliflozin. So as a part of diabetes management, in recent years, they have raised a huge interest considering its favorable effects beyond glucose control. So in type 2 diabetes, who are at high cardiovascular risk, it has found to reduce the major cardiovascular events, hospitalization for heart failure. It reduces the cardiovascular and all-cause mortality and delay the progression to end-stage renal disease. So for this, we have evidence via multiple trials which have been conducted post-2008, which we'll be seeing briefly. FDA has issued a guidance for any drug in diabetes to be marketed should undergo a CV risk evaluation. So it has been at multiple sectors in the form of 3-point MACE, which includes non-fatal MI, non-fatal stroke, and cardiovascular death. And based on all these trials, SGLT2 inhibitors have found significantly to reduce the risk of major cardiovascular events, hospitalization for heart failure, and progression of CKD in type 2 diabetes. So basically, we have 3 major cardiovascular outcome trials. As Sir has highlighted in the prior lecture, I will not go much in the detail, but one thing which I would like to highlight here is the EMPAREC trial, which is a empagliflozin trial, have shown a significant 38% reduction in cardiovascular death, while this benefit was not observed in CANVAS and DECLARE-TIMI trial. However, this results might probably due to the baseline characteristics of the patients. The baseline characteristics with EMPAREC outcome was that the 100% patients had established cardiovascular disease, while in canagliflozin trial, which is CANVAS trial, 66% has established cardiovascular disease, while in DECLARE-TIMI trial, only 40% had the established cardiovascular disease. So considering these factors, the DECLARE-TIMI trial, which is a dapagliflozin trial, have not shown much benefit in MACE and also much benefit in cardiovascular death. So these drugs are particularly more important for secondary prevention, while in contrast, GLP-1 receptor analogs are more important for primary prevention of the cardiovascular disease. As these trials have shown some benefit in hospitalization for heart failure, there was around 30 to 35% reduction in hospitalization for heart failure. But these trials did not have targeted population of hospitalization and heart failure cases. So there were later 2 trials which has been published, which included heart failure cases in NYHA class 2, 3, and 4 with reduced ejection fraction of less than 40%, which included both with and without diabetes. So DAPA-HF trial was a dapagliflozin trial, which showed around 30% reduction in cardiovascular death and primary outcome. Similarly, EMPEROR trial, which was for empagliflozin, shown cardiovascular death and heart failure hospitalization reduction by around 25%. So particularly important in heart failure cases, they have shown significant benefit. Again, in primary cardiovascular outcome trials, there was some benefit in renal outcome too. So we had a targeted outcome trials in the form of credence trial for canagliflozin, which had end-stage renal disease, doubling of creatinine, and death from renal or cardiovascular cause as primary outcome, and which was shown to reduce by 30% with canagliflozin as compared to placebo. And similarly with DAPA-CKD, the similar outcome were found to be lower with dapagliflozin group by around 40% as compared to placebo. So patients with type 2 diabetes and chronic diabetes related kidney disease in the form of urine albumin creatinine ratio of more than 300 and GFR in mid-normal range from GFR between 30 to less than 90 ml per minute were included in this case. Based on these trials, empagliflozin has become the first glucose-lowering drug proven to reduce cardiovascular mortality. And likely this benefit, being a class effect, is independent of glucose-lowering effect of SGLT2 inhibitors, as CV effects are seen despite minor improvement in HbA1c, which is hardly 1%. And the CV benefit appears as early as 6 to 12 weeks at the initiation of the trial. So what is the mechanism? Multiple mechanisms have been proposed for cardiovascular benefit. The most important is sodium excretion. Due to sodium excretion, there is increase in tubuloglomerular feedback, which causes decrease in intraglomerular hypertension, which is the main pathophysiology in diabetic kidney disease, giving you the renal protection. Similarly, sodium excretion will cause decrease in fluid overload and decrease in arterial blood pressure, which will cause decrease in myocardial workload, leading to cardiovascular protection and reduction in heart failure. And also it has intravascular benefits in the form of improvement in endothelial function and decrease in inflammation. This is a bit busy slide. We have mechanisms at multiple sites. The most important is myocardial effects. It will cause decrease in inflammation and decrease in oxidative stress. The other part is classic cardiovascular risk factors like decrease in blood pressure, decrease in weight, decrease in albuminuria with these drugs. The other part is hemodynamic effects. Due to natriuresis, it will cause decrease in your fluid overload, leading to hemodynamic effects. And the endocrine effects in the form of decrease in insulin resistance and increase in glucagon will have some cardio protection. Coming to concerns about SGLT2 inhibitors use, the risk of decay is real in type 2 diabetes. We have seen few cases presenting with euglycemic decay, and the incidence is around 0.5 to 1 per 1,000 person years. That means if we are treating 1,000 people for 1 year, we'll have a one episode of decay. So this evidence is based from the last trials. However, the real life experience can be different due to rampant use of SGLT2 inhibitors in type 2 diabetes. And also in observational studies, the hazard ratio was shown to be around 1.5 for decay. Prevention is the key in these cases. We need to maintain hydration for this patient whenever we initiate on SGLT2 inhibitors. If a patient is insulinopenic, it's better to maintain a basal insulin levels, as basal insulin levels will decrease the lipolysis and thus prevent ketosis. Patients should be instructed on the signs and symptoms of decay, and a high index of suspicion should be maintained, as patients might present with severe malaise and gastrointestinal symptoms in the form of nausea, vomiting, and abdominal pain. At-risk patients should be initiated cautiously on these drugs, particularly old age and insulinopenia patients. The various mechanisms have been proposed how SGLT2 inhibitors is causing decay. The most important is the shift of the SGLT2 inhibitors will cause decrease in insulin secretion and cause increase in glucagon secretion. So the hormonal milieu over here is promoting the beta oxidation of free fatty acids, leading to increased ketogenesis. And the second part is it will cause glycosuria and natriuresis, which will cause dehydration, leading to euglycemic decay. So one should be cautious while initiating SGLT2 inhibitors in at-risk cases. The second concern is urinary tract infection. As it was discussed in last lecture, patients owing to glycosuria are at increased risk of urinary tract infections. Some data, there was increased risk of severe urinary tract infection. However, we have some reassuring data, which was a meta-analysis of 86 randomized control trials. And it included around 50,000 patients, which showed that the risk of severe UTI was not increased with SGLT2 inhibitors as compared to placebo. So, however, this included only the severe UTI cases. The mild and moderate UTI cases were excluded. So probably the mild cases of UTI will be increasing with use of SGLT2 inhibitors. The important concern is genital mycotic infections. In contrast to UTI, the risk of genital mycotic infection is significantly high, which is 3 to 6-fold increased risk, varying from trial to trial. It is twice higher in women than in men in both the arms. And treatment with antifungal medication should suffice. And even in few cases, if it is mild, there is no need to stop SGLT2 inhibitors with mycotic infections. However, the other urinary tract infection should be ruled out before continuing the SGLT2 inhibitors in these patients. Other very important concern which is being highlighted is Fournier's gangrene. FDA has identified around 55 cases of Fournier gangrene in patients with SGLT2 inhibitors between 2013 to 2019. Also, although this are rare and the statistical significance couldn't be calculated, there are few reports with the use of SGLT2 inhibitors, and we need to be cautious with this side effect. There was a concern of lower limb amputation being raised with canagliflozin in CANVAS trial. However, due to this raised concern, FDA has issued a boxed warning for lower limb amputation. But with recent trials, the risk of amputation with canagliflozin is lower than that what was prescribed in CANVAS trial. So the black box warning was been removed by FDA. However, the risk still remains, and we need to be cautious in those cases who are at risk for lower limb amputation, like peripheral vascular disease or peripheral neuropathy. The risk has, luckily, it hasn't been observed with empagliflozin or with dapagliflozin in various major trials. Again, owing to some calcium and phosphorus metabolism disturbances to SGLT2 inhibitors, there is risk of fractures with CANVAS, risk of fractures which was detected in CANVAS program. Again, this risk was not being confirmed in various large outcome trials. And also, it has been claimed that in CANVAS trial, the bone fractures occurred very early, as early as 12 weeks. And also, it was located in the distal part of extremities, so might not be related to medications, and it could be attributed to the falls rather than the bone effect of SGLT2 inhibitors. Now, we'll see use of SGLT2 inhibitor in different subset of population. As we have seen, SGLT2 inhibitors is causing increased risk of decay, and elderly patients are more prone to decay episodes. So SGLT2 inhibitors should be avoided in frail patients. However, there is no particular cutoff of the age beyond which we should avoid the SGLT2 inhibitors. Particularly patients, those treated with loop diuretics, due to increased risk of dehydration and orthostatic hypotension, they are more prone for decay. And caution in older patients who are currently being treated with insulin or sulfonylureas due to risk of hypoglycemia. Second is patients with renal impairment. Initially, there was small reduction in eGFR, which was observed after initiating of therapy. However, this is transient, and over long-term effect, there is reduction in albuminuria and delay in the progression of chronic kidney disease. So the data is reassuring, and eGFR returned to the baseline levels after discontinuation if in any case we found an initial increment in serum creatinine due to AKI. Most important thing is the glucose lowering effect of SGLT2 inhibitors require a normal renal function. And this effect is maintained up to the GFR of 45. So below 45, your glucose lowering effect will be minimal. However, from 30 to 45, the cardiovascular and renal benefits are maintained. So we can use SGLT2 inhibitors up to GFR of 30 ml per minute. New concept being raised here is a partial additive effect of use of GLP-1 analog with SGLT2 inhibitors. As we all know, SGLT2 inhibitors is causing increase in glucagon, which is predisposing to decay. But GLP-1 analogs are known to decrease the glucagon levels. So this can be used as an additive therapy by using both GLP-1 analog and SGLT2 inhibitors. So selection for patients with type 2 diabetes, as we have highlighted, if there is a risk of bone fracture or if there is a risk of lower limb amputation, it's better to avoid canagliflozin. We can go ahead with EMPA or dapagliflozin. Patients with established cardiovascular disease or risk of cardiovascular disease, patients with established heart failure or risk of heart failure, and patients with renal disease or injury, the SGLT2 inhibitors are the initial choice and would have significant benefit for these patients. This already has been highlighted in previous lectures. The position of SGLT2 inhibitors in current guidelines is in patients particularly with ASCVD or who are at high risk of ASCVD, SGLT2 inhibitors or GLP-1 analogs are the initial choice. For patients with heart failure, it is only SGLT2 inhibitors which have shown significant benefit. For patients with CKD and albuminuria and CKD without albuminuria, we can go ahead with SGLT2 inhibitors. At risk of CKD, we can go ahead with SGLT2 inhibitors. One important thing which has been changed from the guidelines from 2018 to 2022 is that the use of SGLT2 inhibitors in patients with ASCVD or heart failure is independent of your HbA1c targets. Even if HbA1c is under target, we can introduce this agent as they are having significant benefit in ASCVD and heart failure cases. In patients with type 2 diabetes and CKD, we should consider SGLT2 inhibitors when eGFR is more than 25 to 30 or urine albumin creatinine ratio is more than 300. And SGLT2 inhibitors should be given to all the patients with stage 3 CKD or higher and type 2 diabetes regardless of glycemic control, as they slow the CKD progression and reduce heart failure risk independent of glycemic control. Before starting the drug, we should weigh the risk and benefits. Definitely, there are benefits more as compared to the risk, which are very rare. The major benefits which we have seen is reduction in HbA1c, weight loss, blood pressure, decrease in major adverse cardiovascular events, heart failure cases, and renal protection. And risk, as we have seen, DKA, amputation, fractures, volume depletion, and AKI risk. So, the take-home message would be SGLT2 inhibitors provide insulin-independent mechanism for glycemic control. So there is limited risk of hypoglycemia unless used with other anti-diabetic agents. The optimal prescribing of SGLT2 inhibitors require a full understanding of the risk in addition to their benefits. And the optimal goal is to exploit the cardiovascular and renal benefits of SGLT2 inhibitors while avoiding the adverse effects. Thank you for the patient listening.
Thank you so much, sir, for such an informative session on SGLT2 inhibitors. Any questions? There is one question from Dr. Sagar Pawar, guide about juvenile diabetes.
Right. I guess Dr. Meghna would be a better person to guide for juvenile diabetes. But regarding the aspect of SGLT2 inhibitors, in type 2 diabetes, we have few research which have shown increase in DKA risk. So till date, it's not been approved in type 1 diabetes and insulinopenic patient. What has been observed is by treating 10 patients of type 1 diabetes will predispose one patient to ketosis. And by treating 20 patients of type 1 diabetes will dispose one patient for DKA, the acidosis episode. So it's better to avoid in type 1 diabetes. In juvenile type 2 diabetes, definitely there is significant benefit in weight reduction. So if they are type 2 diabetes, we can go ahead with SGLT2 inhibitors.
One more question from Pramod Umarji, opinion on remogliflozin.
Yes, remogliflozin has been launched in India and it's been approved in India for clinical use. Although, like other trials which has been for other drugs like canagliflozin and empagliflozin, we don't have a large cardiovascular outcome trial for remogliflozin till now. Although it is a class effect and it has been approved in India, we can use remogliflozin currently.
Another question from Dr. Prahlad Manchekar. Can metformin be given or continued in case of eGFR below 30?
No, metformin is contraindicated less than 30. Metformin can be used between 30 to 45 if patient is already on metformin, and also it should be avoided to initiate metformin between 30 to 45 based on current guidelines.
Okay. Any other questions?
One important thing, the risk of lactic acidosis will be increased if the GFR is less than 30. So it should be avoided if GFR is less than 30.
Okay. Thank you so much, sir.
Thank you.
Moving on to the next lecture by Dr. Neeraj Raite on weight loss management. Dr. Neeraj Raite is a gastrointestinal and general. Shall I continue? Dr. Neeraj Raite is a gastrointestinal and general surgeon with expertise in laparoscopic and robotic surgery for gastrointestinal diseases and pediatric surgery in Ruby Hall Clinic, Pune. He is also a member of DOS Surgical Group. This is a group of surgeons with expertise in general surgery, laparoscopic, laser surgery, and weight loss bariatric surgery.
I think Ritu sir has been logged in.
Yeah, no, so, actually sir has recorded lecture.
Okay.
Thank you so much for inviting me for this topic on weight loss management, choosing between medical and surgical managements. My sincere thanks to Dr. Sanjay Agarwal sir and Dr. Harshal Ekatpure for inviting and involving a surgeon who will be speaking about options when it comes to interventional options for weight loss. We all have heard now what are the different options when it comes to managing diabetes and obesity, and the trends have been changing, and the biggest shift in the trend is because of the COVID. The COVID epidemic has led to creation of polarization. So people who were obese have become super obese, and people who were in the midway have made several attempts to lose good amount of weight. Now this has effectively led to polarization worsening in obese patients, and COVID itself has also contributed in increasing the problems of diabetes, the exact cause of which is still unknown. I don't want to go into the series of before and after pictures, but if we have to see an image where a patient has been taking treatment for his diabetes and taking almost 100 units of insulin, along with having a weight in the range of around 100 to 110 kgs, what should be our focus? Treating his diabetes or treating his obesity is a question we will all have to answer. If you ask me, obesity is a mother of all medical comorbidities, and unless we focus on the root cause, correction of the effects is going to be difficult. So here is an example who has undergone laparoscopic Roux-en-Y gastric bypass, and he is off all his diabetic medications purely because we try to focus on his root cause, the obesity, than only focusing on his medical illnesses. And we do come across lot of patients in our day-to-day practice where surgeons and all the clinicians have to justify our options of treatment. And many a times patient's story when they gain weight is that they are not willing to do anything from their side, and it is the clinicians who have to advise them the treatment options. And probably this is my earnest request to all of us over here, that as clinicians, as a family physicians, as physicians, when all our current medical management options are not effective, we should do enlighten them about interventional options of treating obesity and metabolic syndrome. This is a routine story of patients that when it goes to an exercise expert and he has excess weight, the exercise expert will push him to lot of weight training. If the patient goes to a dietitian, the dietitian will put him or her through a diet regime. If a patient goes to a particular specialist, we tend to look at the patient from that particular ailment only. Whereas we feel that when we are looking at patient, we should look at a patient as a whole, and that is why these kind of conferences really create an impact, because here we are understanding all the possible options which we have when it comes to treating our obese patients having metabolic syndrome. There are some important concerns when it comes to non-surgical options of obesity and metabolic syndrome. A typical weight loss in dietary and lifestyle modification program in patients who have severe obesity is only around 1 to 3 kg per meter square, in comparison to almost 13.5 kgs per meter square after interventional procedure. The attrition rate, the compliance for non-surgical options decreases over a period of time, and dietary programs and lifestyle programs have a high attrition rate despite these therapies being effective or successful for patients. But many individuals, their obesity does not get resolved, and the extent of weight loss is relatively less compared to their overall BMI. Also important concern is not only the science of weight loss, but to maintain the lost weight. We know that lot of patients undergo lot of regimes of weight loss, but the challenge is maintaining the lost weight. And the success rate of 129 centers in the world specialized in outpatient obesity care in treating patients with obesity by medical line of management is just 7% after 24 months. So here is my earnest request to all the clinicians who are attending this conference to take the self-doubt out of their mind. What if is not a choice? Fear of obesity surgery, if it is with us as clinicians, we won't be able to give this option to our patients convincingly. Obesity surgery is in vogue in India since 2000 and world over since 1998. There are enough number of patients who have undergone this surgery for more than 20 years and are living a life very healthy. So here is my question to all of us here. How would we manage this patient who is 40 years old, having a BMI of 40, known diabetic and hypertensive, and not responding to our current medical line of management? Can only medical and lifestyle measures will suffice? And the answer probably is definitely a big no. So here I am sharing what are the recent changes which have happened in the trends of interventional options in weight loss and in bariatric surgery. So understanding of surgical efficiency for weight loss has changed immensely. Earlier it was more focused about losing excess weight, but now the focus has been equally in treating overall metabolic syndrome. So it is no longer only for weight loss, but it is equally also for treating the overall metabolic syndrome. We should not debate whether a restrictive surgery will work, whether a malabsorptive surgery will work, because each patient is different and each patient should have only one surgery as an option to him. So probably we should focus on constructive outcome which is better for our patients. Well, the trend is changing. These days we are favoring more and more reversible bariatric procedures compared to non-reversible bariatric procedures, so that we still have an option of going back to the original anatomy if the need arises, thus reducing the long-term challenges after bariatric surgery. And yes, probably the biggest change in the trend is acceptance not only from the medical fraternity but from the governance, acceptance from the insurance, and more patients are getting covered in their insurance when it comes to treating them for their bariatric surgery. Yes, and also we as bariatric surgeons have started accepting that surgery is not only the way of treating obesity and metabolic syndrome. Surgery followed by continuous diet and exercise along with lifestyle modifications are necessary. So it is no longer me but necessarily we which is going to play a role. Thus, friends, we all know when other treatment options for severe obesity are unsuccessful, it is prudent to consider use of interventional options for weight loss like bariatric surgery within the context of existing guidance. So what are the options? Gastric balloon, sleeve surgery, gastric bypass, one anastomosis gastric bypass, and different newer bariatric surgeries. Here I would love to quote of my teacher with whom I spent training of my bariatric surgery, and he always used to say, help as many patients once and let that surgical option be the only or the last option for your patients instead of doing multiple surgeries or redos for a patient. Endoscopic gastric balloon. An inflatable silicone balloon is placed inside the stomach either by means of gastroscopy or a fluoro guidance under anesthesia, and this balloon is inflated to the capacity of around 300 to 500 ml. This is a purely daycare procedure and it's completely reversible because this balloon is removed after a period of 6 months to 1 year. This is the image depiction of a gastric balloon. Gastric balloon basically decreases the gastric emptying and it needs diet and exercise along with its mode of action. Outcome: weight loss in the range of around 15 to 20 kgs at the end of 6 months to 1 year can be easily achieved with gastric balloon. Success do require a highly motivated patient because balloon needs diet and exercise along with it for good weight loss. Common side effect of gastric balloon in the initial period is nausea and spasmodic abdominal cramps, and patients need to be made aware about these challenges. Once they cope up with these initial challenges, it's very good acceptance and very good outcome. Sleeve gastrectomy is a procedure which is performed laparoscopically where 80% of the excess stomach is removed from the body, and this leads to secreting of ghrelin hormone. The only downside of sleeve gastrectomy probably is that it's an irreversible procedure. Usually it is preferred in patients who are elderly or who are highly comorbid so that it can be quick in, quick out procedure. Standard contraindications for sleeve gastrectomy include a hiatus hernia and a gastroesophageal reflux disease. So preoperative gastroscopy is mandatory before subjecting a patient for sleeve gastrectomy. Gastric bypass. Roux-en-Y gastric bypass is a procedure which is in vogue since last almost 35 to 40 years. It is supposed to be the most gold standard procedure for metabolic syndrome, and the biggest advantage is that it's a reversible procedure. Indications include metabolic syndrome, and usually patients who are having metabolic syndrome, they need additional procedures to have effective weight loss and resolution of their comorbidities. Contraindications include cirrhotic patients and smokers because cirrhotic patients cannot tolerate some element of malnutrition and their cirrhosis can get worsened. Smokers can lead to stomal ulcers, and that is why it is a complete no-no when it comes to bypass. Single anastomosis gastric bypass or a mini gastric bypass is a new procedure which has been there in use for last 5 to 8 years with very effective weight loss. The most important precondition is that patients should be a non-vegetarian patient because their protein demand after surgery is to the tune of 80 to 100 grams of protein per day. Indications for mini gastric bypass include volume eater patients and super obese patients, and contraindications remain the same like any other bypass, a cirrhotic patient and a smoker. So to summarize, friends, bigger trend, bariatric surgery is going to be there as one of the treatment option when treating patients having excess weight with or without metabolic syndrome, and is one of the treatment options to be considered. Only lasting trend for all of us as clinicians is accepting this and adopting to the current generation of practice. I don't want to be generic, or I don't want to be claiming that bariatric surgery can be administered easily without complications and induces appreciable weight loss with statistically significant reduction in BMI and improvement associated with comorbidities. We need to be case specific and patient specific. It is all about our outlook. What looks evil also can be good if our outlook towards the situation is different. Let's not be in conflicting positions, and let's be helping each other for betterment of our patients. Thank you so much.
Thank you so much, sir.
Is Neeraj is logged out?
No, sir. So shall we continue? Or
Neeraj, any questions? Yeah, is there any questions for Neeraj? I can't see him. Is it there?
no, sir. No.
He logged out.
Not this. Yes, sir.
Okay. Take it. Yeah.
Shall we move to the next?
Yeah. Go ahead.
Moving on to the next lecture by Dr. Abhijit Khardare on diabetes and the coronary artery disease. Dr. Abhijit Khardare is working as consultant cardiologist in Ruby Hall Clinic, Pune, which is one of the highest cardiac centers of Pune, and have been trained under masters in cardiology and has experience in dealing with all the cardiac cases. Sir, Dr. Abhijit Khardare, sir, over to you.
Thank you, Ritu, for this wonderful introduction. Let me share my screen. I'm not able to share from my side.
Vijit, there is a arrow at the bottom of the screen. If you see there.
Yeah,
so you can see a share screen button.
Yeah, but it's not sharing actually. Yeah, now it is there. My screen is visible.
It is.
Okay.
Just make it full screen. Yeah.
Thank you, sir, for giving me this opportunity to enlighten on this topic. As CVD risk.
So you're not
CVD. Hello. Am I audible?
Yeah, you're audible.
Yes, sir.
You are. Yeah.
So I will be covering under these headings: epidemiology, pathophysiology of CAD in diabetic patients, approach for prevention of CAD in diabetes, that is primary prevention, a treatment of coronary artery disease in diabetes, mainly ACS and stable coronary artery disease, and what is the role of revascularization, which is the most debatable topic. So Eugene Brunwald already said, surely the time has come for cardiologists to learn more about diabetes and for diabetologists to learn more about cardiology. Perhaps it is now appropriate to establish a new specialty diabetocardiology, whose practitioner will become the frontline troops in this war. There is an increasing prevalence of diabetes. Now there are almost 400 million people living with a diabetes, and by 2045, the value will be 700 millions. Cardiovascular disease remains the leading cause of morbidity and mortality in individual with diabetes mellitus. Moreover, rates of CVD mortality are 2 to 4 times higher in diabetes than those without diabetes. This has been an increasing focus on, so there should be an increasing focus on joint management of type 2 diabetes and cardiovascular diseases. Indian data, there are more than 9 million deaths due to CAD in 2005 in developing countries, out of which 25% occurred in India, and yearly this data is increasing. The mortality rate in India due to MI were 141 per 1 lakh in males and 136 per 1 lakhs in females. So matter of serious concern is that 52% of CAD deaths in India occurred in people aged below 70 years, while the same was just 22% in developed nation. So these are risk factors with type 2 diabetes: physical inactivity, poor diet, smoking, obesity, which leads to type 2 diabetes, and other mechanisms which eventually leads to cardiovascular disease. Diabetes doubles the CVD risk on an average. If we compare the hazard ratio between of vascular outcomes between diabetes and non-diabetes, so diabetes have worst outcome compared to non-diabetics. Compared with non-diabetic individuals, patients with diabetes have a 2-fold to 4-fold increased risk of developing and dying of CHD. All-cause mortality and CVD mortality is high in men and women, those having diabetes, compared to non-diabetics. So CVD in patient of diabetes, it develops almost 14 to 15 years earlier with greater severity, and two-thirds of deaths in people with diabetes are attributable to cardiovascular deaths, and out of which almost half of it is due to acute myocardial infarction. So what is the natural history of type 2 diabetes mellitus? So the patient initially becomes a pre-diabetic, then there is a starting of an insulin resistance, insulin secretion goes down, and naturally there is an increase in a postprandial and fasting sugars, which leads to microvascular and macrovascular complication. So patient comes to us very late after development of diabetes. These are the key manifestation of cardiovascular diseases in diabetic patient: coronary artery disease, stroke, heart failure, and peripheral artery disease. So atherosclerosis and insulin resistance, it's almost a vicious cycle. Insulin resistance leads to hypertension, obesity, hyperinsulinemia, diabetes, hypertriglyceridemia, increase in a small LDL, low HDL, and hypercoagulability. All these things leads to atherosclerosis. So what is the pathophysiology of developing vascular disease in a diabetic patient? Adipocyte biology and inflammation, mainly increase in inflammatory markers, which leads to endothelial dysfunction and endothelial and vascular dysfunction. So mainly the metabolic abnormalities are hyperglycemia, dyslipidemia, insulin resistance that disrupt the normal arterial function and render arteries susceptible to atherosclerosis. They specifically alter the function of vascular endothelium, smooth muscle cells, as well as platelets, in that they promote the atherogenesis. So these are the markers which inflammatory markers increases, and protective markers basically decreases in a diabetic patient, which leads to coronary artery disease. This is a nutshell slide: diabetes mellitus, hyperglycemia, excess free fatty acids, insulin resistance, which leads to increase in oxidative stress, increase in advanced glycation end product, which again damages the endothelium, which leads to vasoconstriction, inflammation, and thrombosis, and at the end which leads to atherogenesis and arterial thrombosis. Why Indian phenotype is at high risk than the other people? In spite of lower BMI, Asians have more abdominal fat, more insulin resistance, high levels of C-reactive protein, low levels of adiponectin, low levels of HDL, high triglycerides, high level of small low density lipoprotein, and increased susceptibility to type 2 diabetes and coronary artery disease. I was showed that percentage atheroma volume and total atheroma volume is higher in a diabetic compared to non-diabetic patient, which leads to plaque rupture and events like ACS. So these are the diabetic coronaries of patient, diffusely diseased coronary arteries, and almost it's like a multivessel involvement of coronaries. Basically there is an altered lipid profile, which because of increase in a free fatty acid, increase in a triglycerides, increase in a low density lipoprotein, and decrease in a HDL, which leads to atherosclerosis. Now this is from this onwards I will be discussing about how we should approach in a diabetic patient in view of cardiovascular diseases. So if patient of diabetes comes to us, we should initially risk stratify this patient primarily in a three group: very high risk, and moderate high risk. Very high risk include patient with diabetes and established CVD, other target and organ damage, three or major risk factor, and early onset of type 1 diabetes, diabetes with a duration more than 20 years for a type 1 diabetes mellitus. High risk patient with diabetes duration more than 10 years without target organ damage plus any other additional risk factor. Moderate risk, young patient, type 1 diabetes mellitus less than 35 years, type 2 less than 50 years with diabetic duration less than 10 years without other risk factor. After risk stratification, these are the new recommendation for stratification of severe risk patient with a diabetes. We have to assess the atherosclerosis by imaging techniques. So mainly include carotid or femoral ultrasound for plaque detection, or which will be a severe risk modifier. Screening of CAD with CT scoring system, calcium scoring system, and ankle brachial index. Carotid ultrasound, that is intima media thickness for severe risk assessment, is not recommended. So how should we prevent this CVD complication in a setting of diabetes? Mainly primary prevention, lifestyle intervention. ADA, AHA have been given the these class 1 recommendation. One is a smoking cessation. Second is a intake of monounsaturated fat should be more compared to saturated fats. Dietary fiber intake should be more. And exercise will be more than 150 minutes per week for prevention and control of diabetes and prevention of CVD in a DM. So all these, lifestyle plus medical treatment decreases the severe risk in a patient of type 2 diabetes by almost 53%. So lifestyle plus optimal medical treatment will reduces the cardiovascular risk by 53%. ESC have given the goals for LDL reduction across all categories of severe risk patient. Initially, we should calculate the score or ASCVD risk score, and we should go and treating the LDL value. It should be at least less than 50% of an initial value. In a high risk patient, we should go more and more down. We should target the 55 value in a very high risk patient. And moderate high risk, it should be around 100, and low risk, it should be around 106 milligram per deciliter. So this is a basic treatment algorithm in a patient with type 2 diabetes mellitus and ASCVD. I think this slide has been discussed by previous lecturers, previous speakers. So what are the recommendations for glucose lowering treatment in DM? SGLT2 inhibitors, again this has been discussed by Dr. Piyush. GLP, and that they have some cardiovascular safety in a patient with diabetes with cardiovascular disease. So trajectories in coronary heart disease prevention, we should risk stratify. If patient is having very high risk, treat with the statins and treat added therapies. The curve will flatten out as we go on treat the risk factors. Statin has his own legacy, that it decreases the mortality, decreases the all-cause mortality, decreases the admission rates, decreases in the event of myocardial infarction, and at the end decreases the heart failure admissions. So ADA in 2021 a recommendation for primary prevention, Diabetes between 20 to 39 years with additional atherosclerotic cardiovascular risk factors, it may be reasonable to initiate statin therapy in addition. Diabetes aged between 40 to 75 years without atherosclerotic cardiovascular disease, use moderate intensity statin therapy. Diabetes at a high risk, especially those with multiple atherosclerotic cardiovascular disease risk factor, or aged between 50 to 70 years, it is reasonable to use high intensity statin therapy. High intensity means 80 mg of atorvastatin and 40 mg of uh, uh, rosuvastatin. In patients with diabetes at higher risk, especially those with multiple atherosclerotic cardiovascular disease risk factor, or aged between 50 to 70 years, it is reasonable to use high intensity statin therapy. So management of dyslipidemia, this is a repeat slide. What are the recommendation of blood pressure control in a patient with a diabetes with cardiovascular disease? So blood pressure control is recommended in patient with DM to lower the risk of cardiovascular events, and the target should be less than 145 by 85 mmHg. So it is recommended that we should use a combination of therapy in this patient to achieve blood pressure goals. In patient having diabetic nephropathy, microalbuminuria, proteinuria, there is a recommendation to use ACE or ARB inhibitors. Simultaneous administration of 2 RAS blockers should be avoided in a patient with DM. What is the recommendation for antiplatelet therapy in patient with diabetes? So antiplatelet therapy with aspirin in DM patient at low risk of CVD is not recommended. So there is no role of aspirin in primary prevention in a diabetic patient. It is a class 3 recommendation. Antiplatelet therapy for primary prevention may be considered in a high risk patient with DM on individual basis. Aspirin dose should be in between 75 to 160 milligram per deciliter in a secondary prevention. And P2Y12 inhibitors other than clopidogrel, that is prasugrel and ticagrelor, should be preferred in a diabetic patient who are at a high risk. Clopidogrel is recommended in a patient who is having aspirin intolerance. So this slide has been discussed in Dr. Herschel's talk. These are the effect of insulin, how insulin is a cardioprotective in a patient with an coronary artery disease. So glycemic control, it is recommended that glucose lowering is instituted in an individualized manner, taking duration of diabetes and comorbidities into the account. It is recommended to apply tight glucose control targeting near normal HbA1c to decrease the microvascular complication in type 1 and type 2 diabetes mellitus. And HbA1c target of less than 7% should be considered for the prevention of CVD in type 1 and type 2 diabetes. That is class 2A recommendation. Basal bolus insulin regimen combined with a frequent glucose monitoring is recommended for optimal glucose control in type 1 DM. Metformin should be considered as a first-line therapy in subject with type 2 diabetes mellitus following evaluation of renal function. What is in a role of treatment recommendation in a patient with ACS and stable coronary artery disease? So every diabetic patient should be on ACE or ARB, I mean hypertensive and diabetic patient. Statin therapy should be there. Statin has a very big role in a primary prevention. Aspirin in a dose of 75 to 160 milligram is recommended as a secondary prevention in diabetes mellitus. And again, a role of ticagrelor and prasugrel in a diabetic patient with a high risk features. Concomitant use of proton pump inhibitor is recommended in patient receiving DAPT or oral anticoagulation monotherapy who are at a high risk of GI bleed. Clopidogrel is recommended in place of aspirin. And prolonged use of DAPT more than 12 months. At the end of 12 months, we should assess the patient for risk of bleeding and other risk factors and risk modifiers, and we can continue this DAPT for should be continued for 3 years. That is a 2A recommendation. Beta blockers may be considered in a patient with ACS and chronic coronary syndrome, those having MI or with angina. What is the role of revascularization for coronary artery disease in diabetes? So what are the recommendation? It is recommended that the same revascularization technique are implemented, but the use of drug-eluting steady as a graft in a patient with a diabetes or without diabetes, it is recommended immediately before angiography, and that metformin should be withheld if renal function deteriorates. Optimal medical therapy should be considered as a stable coronary artery disease and diabetes, unless there are uncontrolled ischemic symptoms, large area of ischemia, and significant left main or proximal LED lesions. Why revascularization is challenging in diabetic patient? Because of diffuse involvement of coronary arteries, higher propensity to develop restenosis after PCI, and graft occlusion after CABG. Then associated comorbidities, that is peripheral vascular disease and diabetic nephropathy. Periprocedural complications are very high in diabetic patient, and outcomes are not good. So see, if there is a suitable anatomy for revascularization in a diabetic patient, if there is a patient has a one vessel coronary artery disease without proximal LED stenosis, so PCI is a class 1 indication, CABG will be class 2B. With proximal LED stenosis, both has class 1 indication. With a single coronary artery disease, for two vessel disease, again without proximal LED lesion, PCI is a class 1. With proximal LED lesion with blockages in a two proximal vessels, the CABG and PCI has a equal role. Three vessel disease, definitely CABG syntax score. If syntax score is between 0 to 22, CABG is a class 1 and PCI will be class 2B. And very high syntax score with a diabetes, PCI is not recommended. CABG is a class 1 indication. Left main with low disease complexity, that means very proximal left main disease, only the single lesion, both has CABG and PCI has the same role. With intermediate complexity, syntax score between 23 to 32, CABG is over the PCI, and with very high syntax score, CABG will be a better option than the PCI. There are some studies who compared PCI versus CABG in a patient of diabetes. So multivessel or left main coronary artery disease who require revascularization, the evidence suggests better outcomes with CABG rather than PCI with a stenting. Early trial comparing early trials were mainly compared balloon angioplasty with CABG. So the CABG found to be superior to balloon angioplasty. But now the new freedom trial and all this, they have been using drug-eluting stent. 1900 patients with diabetes with multivessel coronary artery disease were randomly assigned to either PCI with DES or CABG. Both groups received optimal medical therapies for secondary prevention. Median follow-up was around 4 years. And at a 1 year, there was a higher rate of repeat revascularization in a PCI group compared to CABG group. So high repeat revascularization, which again leads to high risk, high mortality. So that's why CABG was superior to PCI in a patient, mainly in a freedom group trial. Revascularization compared with a DES PCI in patient with left main or other three vessel disease, but a higher rate of strokes were observed. No difference in a death, MI, and thrombosis. Diabetes are especially more likely to benefit with CABG compared with DES PCI. Then now the debate is on whether optimal medical therapy versus revascularization. So revascularization in any form, I mean PCI or type 2 PCI or CABG. In BURRIED 2D trial, around 3,000 patients with type 2 diabetes and stable, mainly this has been studied in a stable coronary artery disease. They were randomized to receive revascularization plus intensive medical therapy compared to only intensive medical therapy alone. So during 5-year, overall mortality rates between the two groups did not differ significantly. So both revascularization group in form of PCI or CABG versus only optimal medical therapy, the mortality was the same. In secondary analysis stratified according to the mode of revascularization, all cardiovascular outcomes were statistically similar between PCI and medical therapy group, but CABG compared with the medical therapy was associated with significant reduction in major cardiovascular. So some sub studies have shown CABG patient have some better benefit compared to PCI. This that still debate is going on this part, whether PCI versus CABG versus optimal medical treatment is better. Now ischemia trial has been published in I think last 2 years back. So this trial have shown that it is in a favor of optimal medical treatment. So if you treat a patient with optimal medications with a good lipid control, good diabetes control, and good anti-anginal drugs, this stable coronary artery patient does better compared to those who underwent revascularization. So take home messages: early detection of diabetes in high risk patients, screening of diabetic patient for coronary artery disease, use of scoring system, that is ASCVD score or score of European guidelines. It should be our OPD tools for daily visiting diabetic patient. Optimal medical treatment for a diabetic patient: use of statin. Statin is have high role in mortality benefit in both primary and secondary prevention, and lower is a better. LDL, we should achieve a lower and lower goals of LDL. No role of aspirin in primary prevention. Revascularization versus optimal medical therapy. Again, this is a mainly in a stable coronary artery disease patient. And naturally, formation of diabetocardiology specialty as an frontline troops in this war. Thank you. So I will end my session here. If any question, will be welcome.
Thank you so much, sir, for such a detailed lecture on cardiovascular disease in diabetic patients. Any questions? Shall we move to the next? Yeah.
I think there are a few questions here.
Oh, yes, sir.
But I think these are for. Is there any change of dose of SGLT2 inhibitor for non-diabetic patient? Dr. Piyush, can you take this? A role of newer insulin molecules in diabetic management. Okay, we will take this question at the end of our this. Can we go ahead, Ritu, Dr. Ritu?
Yes, sir. Moving on to the next topic of lifestyle management, I would like to invite Ms. Gauri Kalane, who is working as a senior dietitian in Ruby Hall Clinic since 15 years. She has completed BTech and has done post-graduation in dietetics. Certified diabetic educator from International Project Hope KEM Hospital under Dr. Yagnik. She'll be discussing about dietary modifications in diabetic patients.
I'm just sharing my screen. Just give me 2 minutes.
Yes, ma'am, you can share your slide.
Yeah, I'm sharing. Give me 2 minutes.
Ankit, can you help Gauri, please?
Yeah, so I'm just
Ma'am, is there any issue?
yeah, there is a connectivity issue.
Can you share the slides at your end, Ankit? if she's unable to do so?
Yes, I can.
Gauri, can you mail him the slides?
Yeah, sure.
Yeah, I'll just share my email ID in the chat box. Ma'am, I have shared my email ID. You can share it on this.
Yeah, sure.
Ma'am, please confirm once you have sent email.
Yes, ma'am. Yes, sir. Send. Just take 1 second. Has it come, Ankit?
Not yet.
But Gauri, since you're there on the platform, your connectivity should be fine. It may be a computer problem to open the presentation. Are you
Ma'am,
able to
actually, what issue you are facing?
Actually, there is a connectivity issue. There is. I'm not able to share my screen.
So you can see a green color share screen button at the down
Yes.
on your window. Yeah. So first open your presentation once. After that, come back to the Zoom and click on the share screen button to share the presentation.
Yeah, sure. So, Ankit, it has sent to your mail ID. Just check once again.
Yeah, one second. No, ma'am, I have not received yet.
Gauri, just see at the bottom, you see an arrow there. Click on that arrow, share screen.
Yes, sir.
Right? It'll open up a pop-up box.
Yes.
You have to click on that pop-up box and say share. Can we do another thing? Just move on to the next lecture and come back to Gauri for the following lecture, and you can sort out problem with her, Ankit.
Yes, sir, we can do that.
So let's move to the next lecture. You mail the presentation to Ankit and we'll come back to your lecture.
Yes, sir, sure.
Yeah.
But Ritu, take the next lecture and then we'll come back to Gauri.
Okay. The next lecture is by Dr. Smita Ingde, who is Deputy Director Ruby Hall Clinic, Pune. She has set up and constantly in process of developing Ruby Hall's physiotherapy and rehab department since last 15 years. Also, an ergonomic practitioner has conducted ergonomic sessions for more than 50 IT companies till date. Health and fitness through exercise is a core area in every possible diagnosis wherever physiotherapy is needed. She is having experience of 25 years in India and abroad in the field of physiotherapy, occupational therapy, and rehab. She'll be discussing about the exercises in diabetic patients.
Hello, good afternoon, everyone. First of all, let me thank Dr. Sanjay Agarwal and team of Diabetic, all the doctors and the marketing team who has given me opportunity to talk about exercises. Let me all explain you that exercise role in diabetes and actually conducting exercise program for diabetic patients is something new venture we have started from last year, and we are still under study, and we are trying to have a lot of case studies because every diabetic patient is different under the guidance of physician and Dr. Sanjay Agarwal. Now, coming to this lifestyle management, we have a shared PPT with Gauri regarding diet, and I'll be focusing more on exercises and ergonomics. So for this, we have also designed in advance some PPTs and videos which are already uploaded on the YouTube. So these are series of exercises for diabetic patients of type 1, type 2 and pre-diabetic patients. So you can go through the YouTube videos, and then you can also these can be shared with you from our technical team if whoever is interested. Now, coming to lifestyle management, as we all know, all the surgeons, all the doctors, and even Dr. Agarwal has mentioned about the importance of lifestyle management in diabetes. It's very, very important because patients are obese, and that is how, because of obesity, they land up into blood pressure and blood sugar increase. So exercise is a very important role. Not exercise is one of the part of lifestyle management, but it's an important aspect of managing type 2 diabetes. So bringing about change in the lifestyle to limit the blood sugar level and optimize the uptake of blood sugar by the body. So we need to schedule our meals, medications, and follow a proper exercise protocol adhering to it. So eating healthy, exercising, getting checkups, regular checkups, managing stress, stopping smoking and alcohol. If anybody is doing that on regular basis, then that needs to be really taken care of in your lifestyle, a big major lifestyle change. So limiting the amount of time spending sitting, because sitting is something causing sedentary workers to become obese, and that's how the inactivity which lead to again BP and sugar. So ADA standards of medical care in diabetes recommend taking breaks every 30 minutes, and while during this break we're supposed to do certain stretching exercises, leg extension and walking. Now, in a lot of my ergonomics presentations, which I have also uploaded on YouTube, I have actually shown how to do exercises for the neck, for the back during you're traveling in a car for a very long distance to your office, or sitting at your office. So what exercises actually you are supposed to do, I have already shared all those videos. Can we have a next slide, please? Yeah, so exercise and type 2 diabetes, primarily we are talking mainly about concerns of type 2 diabetes. So it promotes cardiovascular fitness and weight loss, promotes the uptake of blood sugar by the cells and decreases insulin resistance, reduces anxiety and promotes mental health. Proper exercise schedule has to be maintained, and blood sugar levels has to be continuously monitored before, during and after exercise. And it's very important that we stay hydrated. Can we go to the next slide, please? Because I want to talk more about the FIT principle according to the ACSM guideline. Here we follow mainly FIT principle, that is frequency. F stands for frequency, I for intensity, T for time, and T for type. This is very important, where we design aerobic resistance and flexibility exercise and strength training. So according to FIT principle, frequency should be 3 to 7 days per week. The intensity we calculate as 40 to 60% of VO2 max and VO2 reserve, corresponding to an RP of 11 to 13 on a 6 to 20 scale of Box scale. So better blood glucose control may be achieved at higher exercise intensity, that is more than or equal to 60% of VO2 reserve. So individuals who have been participating in regular exercise may consider taking this exercise intensity to the level of physical exertion, wherein we can feel the heart rate moving higher, so that's the level of physical exertion. So that's how we can calculate. And a very easy way to calculate what we can tell the patient is, as we consider for the stress test, that is 220 minus person's age, that is a maximum heart rate, and we can set a target of about 75% to 80% or 60% to 75% of the maximum heart rate, because it is very difficult to achieve maximum heart rate immediately if a person is new for exercises and to start the exercises. This is my personal experience. So obviously we go for 60 to 75% of the target heart rate while performing the exercises. Now VO2 max can be calculated in hospital and clinical settings by ergometer. We do have ergometer on Rubiol also to calculate VO2 max, or otherwise 6-minute walk test, which we are regularly doing for pulmonary patients also. So next comes to time. Time is minimum of 150 minutes of activity in a week to 300 minutes of activity for maximum benefits. So how we can distribute the exercise protocol throughout a week is 30 minutes of activities for 5 days or 50 minutes of activities for 6 days. Now this will be also individual case based, because every patient is going to have various diagnoses along with diabetes also. Somebody might have hypertension and other associated, they might have joint pain, arthritic conditions, spondylosis and so on. So every case is going to be different for us when we design an exercise program. So it has to be a very individual exercise program. The type of exercises are aerobic exercise that involve large muscle groups and the rhythmic movements in bouts of at least 10 minutes. So 10 minutes of aerobic or cross trainer or treadmill or other large rhythmic actions are considered while doing, and these are spread out throughout a week intervals. So we have very nicely shown in our videos which are there on the YouTube. Resistance exercise are very important for strength training and muscle toning up. So we are doing combination of all these exercises when we are designing an exercise program. Can we go to the next slide, please? So diet, as Kalane will be telling you about the healthy diet, so I would not focus more on this, but generally we have to eat freshly made balanced meal. Every meal should be a good mixture of starch, proteins and fats. It should include foods that are good in fiber content. Avoid oily food, of course everybody knows about, and oil is a very big, there is a big chapter on oil when it considers for diabetic patients and for of course for cardiovascular diseases to be prevented. Reduce intake of foods with high glycemic index. Drink plenty of water. Avoid carbonated drinks and processed food. Eat food that is easy on your stomach, easy for digestion, and coordinate your meals with medications. Next, please. Stress management is a very important part of diabetes, and in this we have to follow a lot of ergonomics for your mind also along with the body. So we have to incorporate activities in our daily life that promote relaxation and encourage activities like yoga, meditation, deep breathing exercises. Morning hour is actually the best time to start these exercises, but during our work schedule also throughout the day we should make a point, people who are working 9 to 5 or 8 hours duty, we should make it a point to have relaxation techniques and exercises even at your offices or your workplace. Even for us and our doctors also, it is very necessary that we have to learn to meditate even while we are doing our daily work. And everybody can have their hobbies. Hobbies are very important in order to keep oneself stress free. So even if you play badminton after going home, or table tennis, or while you're watching TV and you're watching your favorite serials, you can have a walk in your drawing room. So a lot of hobbies can be there which can give you stress relieving. Next, please. It's very important that we have to keep checking our sugars. We always send the patients to our physicians and diabetologists. We recommend them that you first, before even starting the exercise program, we should know your blood sugar level even after doing the exercises. But on regular basis, HbA1c should be done after every 3 months. That's what we tell our patients who are coming to a physiotherapy OPD. Then most important part of diabetic protocol is also examining the food every day, because they might land up into the scaly foot and the callus formation or corns formation. So taking care of the foot prevention is very important. So even that area we cannot, even though we are working for physiotherapy area, but still we have to take care of all these aspects, even the eye checkup. So we do recommend them doing all these checkups at least twice a year. Next, please. In one of the presentations, there was a very important aspect about smoking and alcohol. So very important lifestyle change is required to people with smoking and alcohol consumption. Now there are a lot of studies which show that if a person is really addicted to smoking, but how much to smoke and how much not, and how much alcohol to be consumed and how much not, how much alcohol can be consumed by a female and versus male, even those studies are there. But the best way is if a person can avoid smoking, because it, of course, everybody knows that suffering from diabetes, it increases the risk of vasoconstriction and small arterioles, and also it can lead to blood vessels and eyes and kidney damage. Nerve damage is of course known with smoking and alcohol consumption. So alcohol adds to an unwanted carbs intake. So definitely if somebody can prevent alcohol or minimize it under the doctor's guidance, can be a better option for lifestyle management. Next, please. Yeah, ergonomics is a very favorite topic of mine, and what I have seen in last so many visits to my IT companies, you know that we have Hinjawadi Hospital where it's all IT professionals are there. So we got an opportunity to go to almost more than 50 IT companies over there all around, and they're all sitting and working in front of the desks and computers and not really following their way, the posture. So we as a therapist will go to the desktop and actually teach them how to sit in front of the computers and what exercise has to be done during the rest intervals. Now there is another challenge nowadays, that is working from home, and for working from home, of course, people do not follow ergonomically designed infrastructure, but they should really spend on this infrastructure, and all doctors, physicians, and even we as therapists, we should recommend that you should have a proper infrastructure which is ergonomically designed, chair and a desktop. That's what they need for working, and rest intervals during the exercises. And most important part is organizing the work, planning and moving instead of long sitting. So sit to stand workstations are the new now very much they are available in the market, also on the nets also. So we can ask them to purchase sit to stand workstations, and nowadays a lot of companies do have these kind of workstations. So, and the rest intervals, as we said, during the sedentary work is a very important part, in which micro rest can be given not only to eyes but to your mind, and also the stretching exercises for the body. Next, please. Prevention of expected long-term diabetic complications. Now we are closely working here with Dr. Agarwal sir and also vascular surgeon for diabetic foot care. In our OPD, we have designed a form for diabetic foot care, in which we are checking the sensory motor issues of the patients. We are asking them questions, and we have designed an evaluation form where we are asking the patients about their foot care, whether they are taking foot care or not, and what is the status, what is the sensory status of the sole and the foot, and for how long they are diabetic. If they are chronic diabetic, then we do suggest them to go to the orthotic and prosthetics, who would design a proper footwear for them, so that they would not develop any pressure sores and cons and ulcerations ahead. So this work is going on in Rubiol. Also, we are recommending offloading shoes to the patients who have already developed gangrene and their amputations. So this is another area which is a very big area, and we do also have scanning equipment on which we ask the patient to stand and have a weight bearing, which will give us the foot impressions, and accordingly we design the insole for the patients, which are soft and which will have all the pressure points, and then we correct those pressure points with the help of the orthotics. Next, please. Yeah, so now this is a YouTube link, and our technical team will share all the videos with you, because when we say exercise means I have to actually show the demonstrations of how we have designed the exercise program. And this you can go to the YouTube link which is there, it will be shared. Otherwise also you can go to Dr. Smitha English Smart Exercise, and you can see these exercise links that are designed, and we are ready for the comments. Thank you so much.
Thank you so much, ma'am, for your useful tips. Can we move on to the next lecture by Dr. Gauri Kalane?
Yeah, I'm ready now. Just ask Ankit for the slides.
नहीं।
Hello, good afternoon to all delegates and all participants. Sorry to trouble you all for the inconvenience. Before my session, all speakers have discussed about the pathophysiology of diabetes, and even you all know about it. Now we will start. The next slide, please. Now we will directly start over our session with diet part. Diet is equally important along with medicine. Uh, while planning a diabetic diet and other types of diet, we all dietitians start with screening methods based on ABCD. A, like anthropometry, in that we measure BMI, BMR, waist and hip ratio. Along with that, we check all the biochemical parameters, all lab reports, and the recent one. We counsel the patient and as well as the relative. We require some diet recall and some food habits and the prescribed diet, uh, which is given by the doctor. And after examining all ABCs, we plan a diet and explain lifestyle modification and diet to the patient and the relative. Next slide, please. There is an important message for recently diagnosed diabetic patients. Diabetic diet is not a tailor-made chart. Every diabetic diet is a personalized plan based on patient's age, comorbidities, lab reports, medical history, and present medical condition. There are different diet plans as per type of diabetes, like type 1, type 2, and gestational diabetes. Everyone will get different diet charts on one click of Google, but all are not made by authentic sources. So, with the help of endocrinologists, diabetic educators, and nutritionists, do follow all medical and dietary instructions. Next slide, please. There are some tips for recently diagnosed diabetic people. Patient can have small frequent meals, at least 3 to 4 meal pattern in a day. Take plenty of water, at least 8 to 4 glasses. Along with that, other fluids like fresh soup, buttermilk, dal water, and coconut water also. Include more of protein for cell recovery. The sources are all dals, sprouts, milk and milk products, soya products, all non-veg items. Other food group like more of roughages can have in the diet. Roughages means fiber. Those are rich in complex carbohydrates. Those are help to reduce the cholesterol also, and it will reduce to blood sugar level also. The sources of roughage, that is fiber, is all green leafy vegetables, raw salad, raita, and fruit with skin and oats. Avoid outside eatables, ready-to-eat foods, spicy, oily, fast foods, and bakery items. Next slide, please. Make some innovative homemade recipes for type 1 children. As Dr. Meghna also told that type 1 diabetic children, to treat type 1 children, it is a very much challenging job. So, because those children are very much choosy and fussy about their food, so we have to convince the patient also and their parents. So, we have to make some recipes. So, I made some innovative recipes. I'll share with you all. It is good for adult people also. For example, there are some sprout dishes. You can make a sprout bhel, sprout pav bhaji, stuffed sprout with paneer. You can make some delicious breakfast items like upma, which is made up of dalia or oats or sev or suji. Put lots of vegetables in it It will help to reduce the glycemic index. Make some frankies or egg rolls, which should be not a deep fried. It's a shallow fried recipe. You can make vegetarian frankies and non-veg frankies also. You can make paratha, like vegetable paratha and non-veg paratha also. We make normal idlis and uttapam and a dosa. So put some minced vegetables in it. Make some whole moong chilas and tomato basin omelets. These are the some breakfast items as well as the other dinner item also. Avoid simple sugar, jaggery, honey, sugar-free juice, and sweets. Avoid outside food, ready to eat, tin canned foods, and all chocolates, cake, pastries, cold drinks, and soft drinks. Along with the diet, do 1 hour exercise, physical activity, as Dr. Inge told us, like gym, swimming, cycling, running, jogging, yoga, or Zumba. Use very less salt while cooking diet. No added salt is recommended. Next slide please. I'm sharing one of my sample menu for diabetic patients. Just have a quick look. In this menu, I mentioned different kind of meals, meal timing, food options with quantity. These points are very much important while monitoring the sugar in a day. Next slide, please. Every menu is divided into 4 to 5 meal patterns. The menu which we are giving to the patient, it should be in a simple language with many options, which is easily understand by the patient and their relative. Next slide, please. Okay. This is dinner. Next slide, please. Okay. After the day's diet, I have given some food group lists with allowed and avoided food items so that even layman can easily recognize the regional foodstuff and ingredients while cooking diabetic recipes. Just take a quick view. In cereals, patient can't have bakery items or other meta products. Instead of that, some homemade recipes of wheat, ragi, and dalia, vermicelli. It is good for diabetic people. Then avoid salted and thin sprouts. Whole sprouts and all dals are recommended for diabetic people. Then all soya products are also included. In leafy vegetables, those are rich in micronutrients also. Those are rich in complex carbohydrate, that is fiber. Include twice a week leafy vegetable, twice a week pulses, and twice a day salad should be there or raita should be there in day's diet. Avoid starchy, high calorie vegetables like potato, sweet potato, yam, beet, raw bananas, raw jackfruits. Okay, in milk products, you can have any milk, but you have to remove the cream, and without cream, curd, buttermilk, plain milk, and homemade paneer patient can have. Just avoid the cheese, butter, cream, and khoa. Next slide, please. Next slide, please. In fruits, diabetic patient can have fruits before 6 p.m. In a day, patient can have whole fruits with skin as much as possible. Just avoid banana, grapes, mango, chiku, all fruit juices. Eat fruit with skin as much as possible because it gives more of fiber. Then, if patient is a non-vegetarian, then patient can have egg whites. Just prefer the egg white. If the frequency is more, then patient can have egg white like twice a week. Otherwise, once in a while, whole egg is also good for the patient. And patient can have chicken and fish. The non-veg items should be like boiled, grilled, roasted, or tandoor or baked. Just avoid the yellow part. Once in a while, it is okay, the egg yolk. Otherwise, just avoid the yellow. Organ meat, shellfishes like crabs and prawns. because those are high in cholesterol and saturated fat also. All the diabetic patients, along with, if patient is having cardiovascular complication also, this patient can have any oil or blend mix. You have to keep on changing your oil after every 2 months and use only for the tadka purpose. No deep fried foods are allowed for diabetic patients. And other miscellaneous foods like ready to eat foods and mayonnaise and other like papad, pickles and all are avoided. And instead of that, if a patient would like to eat some if patient is feeling hungry and if he want to eat in between meals like mid morning and mid evening, patient can have like a feast of dry fruits, puff murmura chuda, plain khakras and makhana. That patient can have, which is low in calorie and easily digestible, also good for diabetes. Next slide, please. I'm sharing a food pyramid for we all. So in the first look, everyone can get a brief idea about the selection of food. Like in the base, there are some leafy vegetables and fruits. The intake, the consumption of leafy vegetables and fruit with skin, it should be more, then less of carbohydrate. The simple carbohydrates we have to reduce, and instead of eating simple carbohydrates, those are rich in starch and more of simple carbohydrates. We have, instead of that, patient can have complex carbohydrates. If patient is taking like pasta or any bakery items or any continental dish, so along with that some sauteed vegetables patient can have. Then more of proteins, less of fat, and less sweet. Okay, this is just a brief guideline. That's all about my side. This is just a brief guideline about that. Thanks for your valuable time and support, even though today is your weekend. If you have any queries, just discuss now or afterwards also. Have a nice weekend.
No, ma'am, there is no any question.
Hello, Dr. Ritu, mute yourself and start.
Yeah, actually, there are a few questions there. If anyone can answer.
Ma'am, actually no one is there right now, so you can give the vote of thanks and close the program.
Thank you to all the speakers for their time and
Meghna ma'am, can you give the answer
answering some questions.
questions? Dr. Keskar and Dr. Karnavir. Hello, Dr. Meghna. Hello, Dr. Meghna. Hello. Dr. Ritu,
Yes.
please go for a vote of thanks and close.
Yeah, please. We are hungry now.
Okay. Thank you to all the speakers for their time and sharing some good knowledge about diabetic management and lifestyle modifications, and to all the audience for joining us today. Hope you have a wonderful session. Thank you.
Thank you.